So we're going to get started. So my name is Erin Madden. I'm an assistant professor at Wayne State University in Family Medicine and Public Health Sciences. I'm an addiction researcher, and I'm here with my co-presenter, Bree Rowe. I'm going to let them introduce themselves.
Hi, I don't like using microphones. My name is Bree Rowe. I use she, they pronouns, but I prefer they. I will not get upset if you guys use she. I work as a harm reductionist in Wayne County, specifically Detroit, serving underserved populations such as the unhoused or folks that are practicing sex work or just experiencing different intersections of adversity while using substances, including parenting or having to go through the birthing process while using.
Great. And so we're going to be talking today about harm reduction and stigma and have special attention to families experiencing substance use disorder. Also, as an aside, both Bree and I are parents. This is my second, so I already have one, and Bree has 4 children, right? So we're talking about this mostly from a professional perspective, but also Bree is going to talk about some of her experiences with parenting and substance use from a firsthand perspective as well. So she is both a professional who deals with this, and this is her expertise, but also has some lived experience as well. Okay, so we have no conflicts of interest to report. I work at a medical school. You have to say those sorts of things. Some of us do get money from places, but not me. So we're going to talk about some of the key concepts around substance use. We're going to talk about what causes substance use disorders and some of the recent data from the national level in Michigan. We're going to talk about stigma towards substance use. Bree's going to talk about her story. Then we'll have a little break. Then we'll talk about how to reduce stigma, which is the million-dollar question. Then we'll talk about harm reduction resources in the Detroit area, southeastern Michigan area. And then we'll have some discussion about how we can actually move towards incorporating some of the concepts from today, like stigma reduction, harm reduction, into social work practice and other social services. So our goals for this training are to describe forms of substance use stigma and how these affect patient and client outcomes. A lot of times people think stigma is just like really overt, really mean prejudice, like, you know, using like epithets, but stigma can be much more subtle, so it's important to understand sort of all the ways that stigma can look. And how these are really negative impacts on patient and client outcomes. We're also going to talk about using evidence-based public health approaches. So by that I mean like science-backed ways of addressing substance use, like harm reduction, medication treatment, and what's called patient-centered care, instead of punitive measures when working with parents who use drugs. A lot of us have been primed and have been raised on this idea of tough love and punishing people who use drugs, but that's actually not the best approach. It doesn't get us the best outcomes, so what do we do instead? The third goal would be to implement harm reduction values and strategies in your work. We don't know exactly what that could look like. We hope some discussion will help us identify some ways to do that with you. And then recognizing the importance of, whenever possible, keeping families together even when a parent uses drugs, which is typically not the way many of us have been taught that we should approach parents who use drugs. So this could potentially be a new idea, or maybe you are already doing this sort of thing. So we'll start with the terminology and key concepts. So we're going to be using some sort of like official, sort of more clinical language. So typically in medicine, we refer to addiction as a substance use disorder. This is a diagnosis, right? But typically when we're talking to our friends, right, we refer to it as an addiction. So addiction is sort of the colloquialism that we use for substance use disorder. And I want to emphasize that a lot of times we think of substance use disorders as a lifelong chronic disease, and they might be that for some people. They can be a chronic disease that affects the brain and has sort of ongoing biological, psychological, and social problems associated with it. But actually for some people, substance use disorders or addiction is not chronic. This is something they completely recover from, and it is not a chronic condition at all. It is more of an acute condition, so that means short term, and people can completely recover without ever using drugs again. And that's sort of under-recognized in the public discourse, and sometimes actually among researchers as well. We tend to overemphasize the chronic nature of some people's substance use, but that's not the case for everyone. So how do we identify addiction? So there's 11 actually criteria that we used, created by the American Psychiatric Association in what's called the DSM-5. I'm sure you guys are familiar with it. So people have to meet these criteria to be diagnosed with an addiction. Sometimes people just think problematic use is sort of like a use that maybe is a little bit risky as an addiction, but that's not enough alone. So they have to meet at least 2 of these criteria to be diagnosed with substance use disorder. And so that can be things like taking a substance in larger amounts over a longer period of time than was intended, maybe unsuccessful efforts to cut down or control substance use. People spend a lot of time trying to get their substance, craving the substance. And then 5, 6, and 7 are sort of social outcomes related to that. So unable to fulfill work or social life obligations because of their drug use. They continue to use despite it causing significant social problems in their lives. Their social work activities are reduced because of use. They might be using substances in situations that are physically hazardous. They have continued substance use despite having persistent, recurrent physical or psychological problems. And then the last two are what's called types of physical dependence. If these are the only two that someone has, we actually don't consider them having a substance use disorder. So there's an exception to that two, like meeting these two criteria at minimum rule. So if someone has just tolerance or withdrawal, not enough to diagnose them with an addiction. So tolerance is when someone has either a need for increased amounts of a substance to achieve the desired effect, or there's a diminished effect with continued use of the same amount of a substance. Withdrawal is, we all kind of know what withdrawal is, right? But when someone has sort of a characteristic withdrawal syndrome, so that for opioids, that'll be like flu-like symptoms if they stop using, or taking a substance to relieve or avoid withdrawal symptoms. So number 10 and 11 do not meet the criteria of addiction alone, because if you think about it, someone who is insulin dependent, right, is meeting actually 10 and 11. But we wouldn't call someone addicted to insulin, right? They need it to function. If they have tolerance to it, and they would withdraw from it if they stopped using it. So that's why we don't consider those two alone enough. There would have to be a third on top of those to qualify. So if someone has about 2 to 3 of these symptoms, we consider them having a mild substance use disorder, 4 to 5 moderate, 6 or more severe. So I just want to really emphasize this point. The last two indicate what's called physical dependence, but they are not addiction. So drug dependence, also called physical dependence, is a biological consequence of taking a medication for a long period of time, okay? This could be weeks for some types of medication or years for other types of medication. So you have tolerance, withdrawal symptoms. It can occur with prescribed medications like insulin. It can also occur with alcohol or illicit drugs. Addiction is when you have the continued use of that drug that persists in the face of the negative consequences. So like the 5, 6, 7, 8 criteria being really important for adding on to the last two to meet the definition of addiction. We're going to be talking a lot today about stigma. So people who use drugs are often stigmatized a lot. What stigma means is 2 things. It's when there's both prejudice, so those negative attitudes, and discrimination, negative actions towards an individual because of a particular attribute. And stigma can be intentional or unintentional. Sometimes people think, well, I'm not a stigmatizer because I didn't mean to do something wrong. But racism is a type of stigma, and we know that racism is not always intentional, but that it happens, right? So stigma towards people who use drugs operates similarly, not the same, but similarly, right, that it doesn't have to be intentional for something to be stigmatizing. We're going to be talking a lot today about harm reduction, which is a public health approach to risk reduction. Bree in her work is a harm reduction practitioner. This is both a set of values and strategies that are aimed to reduce the negative social consequences of drug use, and it can refer also to reducing harms associated with other behaviors. So, Bree, you always give a good example of helmets. Do you want to sort of explain?
Yeah, because I think one of the first debates I often get in like a professional setting for people that haven't used harm reduction practices in their own provider circumstances is that it enables drug use, and they very much connect harm reduction specifically to substance use disorder or folks that are using substances or doing other behaviors that they deem negative and stigmatized against. Therefore, harm reduction is like an enabling thing to a negative human condition, right? But when we remind folks that we practice harm reduction on several levels, right? Helmets are a big one. Helmets on motorcycles is the example I use all the time, because when they made that like an option, right? Like a few years ago, they said it's like an option for you to protect your skull and brain from serious injury on a motorcycle, right? We gave humans the option to just not do something so simple that could literally save their life, but we did it. And when people choose not to wear a helmet and get hurt, they get treated, and they do not get shamed, and they do not get told that they were dumb and didn't use a helmet, and that people enabled them, and that this is why this law, all of this, and it's harm reduction. We tell people use a helmet because if you're doing something risky, like motorcycle, right? Like we know that people die every day on motorcycles. If you're choosing that risky behavior, it's not considered criminalized or something that we need to stigmatize against because it's a motorcycle, then you need to use harm reduction practices to make that experience as safe as you possibly can. And once again, I think the biggest part of that example that hits home is that in that scenario, nobody gets negatively impacted. The motorcycle rider who doesn't choose to be safe, despite knowing that a motorcycle could kill him. Okay, that conversation sounds very familiar. Well, if they used heroin knowing that it could kill them, that's what they deserved. But folks get on motorcycles without helmets knowing that people die every day in that same scenario and are not treated differently because of it. So we practice harm reduction with seat belts, with helmets, with car seats, with making sure we're walking on the sidewalk, with looking both ways, because those are all behaviors that we do naturally that have inherent risk involved.
Yeah, perfect. Yeah, so harm reduction tends to be used for drug use, but it could be used for all sorts of public health risk reduction interventions. We're also going to talk a little bit today about trauma-informed care, which is an approach to care that Bree uses in her work. I'm sure many of you are familiar with it already, but this is the definition from SAMHSA, which is an approach to services that realizes the widespread impact of trauma, understands potential paths for recovery. We're going to be talking about trauma and its role in drug use in a little bit. And it recognizes the signs and symptoms of trauma in clients, families, and staff, and others involved in the system, and then responds by fully integrating knowledge about trauma into your policies, procedures, practices in order to resist re-traumatization. And so trauma-informed care is really important. People use drugs. One of the biggest risk factors for substance use is experiencing trauma, especially in childhood. So we're going to get into that next. We're going to talk about some of the causes of substance use and then some of the data on overdose in particular that is specific to Michigan and then for the broader U.S. So what causes addiction? What causes substance use disorders? Well, addiction is not caused by some of the things that we commonly hear in the media or in movies that cause addiction. So it's not caused by lack of willpower. It's not caused by weak character. It's also not caused by this idea of addictive personalities, right? That's actually not something that we have like clear evidence that that certain types of personalities become addicted to drugs more than others. Addiction is caused by sort of a mix of genetics and biology, but genetics also don't equal fate. So just because someone in your family had a substance use disorder, you may have inherited genes that maybe they had that increase your risk for substance use disorder, but you may not. The way genetics are passed down is complicated. It's not automatic. So some people, of course, if they have addiction in their family, prefer not to use substances to avoid that because they don't know if they have the genes or not. That's fine. But again, genetics is not fate. Just because someone in your family had an addiction doesn't mean everyone in the family has that same genetic profile. Social conditions, perhaps most importantly, contribute to addiction. So that's what we mean by environment, and so we'll talk about some of those factors. And then genetic and environmental factors do interact with each other. So if you have that gene profile that makes you more susceptible to addiction, and you're in a high-risk environment, neighborhood, social situation, those genes can be more activated. We call this research that sort of identifies that process epigenetics. And but if you're in a social environment that is less risky, those genes might be less turned on, and then you're actually less at risk. So environment and genes sort of interact with each other. So what are some of those social causes? So on the left side here, we have some of the risk factors for addiction. Those are things like availability of drugs at school. Of course, kids are impulsive. They don't have long-term outlook as that, like a lot of us develop in our later 20s, right? So the availability of drugs in school is a big factor. Lack of parental supervision, but also that community level. Community poverty is a big risk factor. And then those adverse childhood experiences that you all are likely already familiar with. And then I really want to emphasize the protective factors, not just things that put people at risk. So positive relationships, parental monitoring support, neighborhood pride, school anti-drug policies, that these can all help, especially in those youth years, for reducing exposure to drug use. We do know that the earlier people are exposed to drugs, the earlier they start using them, the higher their risk for addiction, but again, not automatic. I was a person who used drugs a lot as a younger person. but I did not develop any sort of severe substance use disorder. So it's not something that everyone struggles with just because they started drug use young, but we would like to reduce that, though, because it is a risk factor. So focusing on the adverse childhood experiences measure. So I'm sure you all know what ACEs are, this adverse childhood experiences concept. They are a basic measure, though, of traumatic childhood events, such as abuse, neglect, and witnessing experiences of domestic violence. But I do want to point out one thing. So this is a common picture from that people used from the Robert Wood Johnson Foundation about types of traumas in childhood. And I want to point out one on the left side here, which is they put it as substance abuse. I don't use the word abuse as it relates to drugs, and we'll talk about why later. But substance use in the household is often framed as a traumatic event. But that's actually controversial because some types of substance use in the household can be traumatic and other types are not traumatic, but we're actually pretty bad at differentiating between them in studies. So I also want to point out that the ACEs, we often use it as a screening tool in different interventions, but that's actually not what it was designed for. And the people who made the ACEs measure caution against doing that actually, because it doesn't measure the timing, the frequency, or the intensity of any traumatic experiences. And that's sort of what I'm getting at with this substance use piece of ACEs. How intense was that substance use? Was it frequent? Was it a period of just 6 months where a mom was drinking a lot but then got an intervention and recovered? That's very different than a lifetime or an entire childhood of problematic drinking among a parent, right? But the ACEs don't typically capture that. So in research, we actually try to only use the ACEs tool as sort of like a population level measure of childhood stress. And by that, I mean, we don't use it to assess individual risk. We use it to look across a population at risk. And the inclusion of parental substance use is controversial. Sometimes actually people advocate for leaving it out because of how imprecise that measure is. Like my parents drink a lot of alcohol, but they wouldn't have an alcohol use disorder, so what sort of meets the definition of that traumatic event in childhood is sort of fuzzy for this one in particular. And substance use really exists along a spectrum. So parental, like I sort of mentioned, parental substance use could meet the definition of a substance use disorder, but it also might be somewhere in the middle where it's like social or recreational use of drugs. And we need to recognize that there's some types of substance use that are lower risk and are potentially not even traumatic at all, and some that are higher risk and are traumatic. So like lower risk, and I might be rocking your world a little bit with this, it's not just like drinking wine at dinner, but it could be something like occasional smoking, or actually vaping. It would be of methamphetamine that's been tested for fentanyl contamination, right? So that person is actually making sure that they're, not going to overdose by accident on opioids. They're not injecting, so they're using it in a less risky way. That is a lower risk way of using drugs, and they're not using it all the time. So social use means I just use it sometime with friends. Higher risk, and this might be traumatic, would be things like injecting illicit opioids without another adult present, because then you're at higher risk for a fatal overdose. There's no one there to respond. Or driving during alcohol intoxication, putting yourself at risk or other people at risk, right? Those are riskier behaviors. So we have to recognize that some types of substance use are more risky than others. Some are traumatic and some are not, and that's an important differentiation or difference to sort of make.
And some of it's like acceptable and some is not. I've had conversation a lot in like parenting rooms where I'm like really advocating for the idea that substance use isn't inherently traumatic for a child to experience when their parent is a substance user. And I often remind folks that these trainings and conversations are not happening around folks that grew up in homes where alcohol was prevalent at all times. Like that is an acceptable form of substance use. Thinks, I wonder if that person is the way they are because their mom drank, Like we have this idea in our head that because it's so readily accessible, because it's regulated, because it's legalized, over the age of 21, because it's something that we connect to joy and to pleasure and to social environments, like we've been so deeply ingrained to believe that alcohol is just a part of life like water, that we don't create trainings or stigma and we don't have to convince people to negatively stigmatize or put in a box parents that use alcohol every day. I know plenty of people that are raising their children while also drinking wine every day. And nobody is questioning if that childhood is going to be a traumatic experience for those children growing up in those houses. Nobody is knocking on those doors, removing children from that care. And nobody is even creating data and studies around whether or not growing up in a home with ample alcohol prevalency is causing long-term trauma or like need for care, or increasing risk of drug and substance use, you know.
And we do know, while opioids are the main driver of fatal overdose, alcohol actually contributes much more to morbidity, so that means illness in our population, than opioids do. It's just opioids, like, you know, you're more likely to have a fatal outcome, but alcohol use is actually responsible for higher rates of illness and healthcare costs than opioids are. So.
And alcohol is the substance that you die from in detox, you know, like that's, the reality is that alcohol is extremely dangerous, and we do not view it through the same lens as substances that we're told are illicit or dirtier.
Yeah. And this is not to demonize alcohol. I am a person who drinks alcohol, but that we need to understand what is safer use and what is less safe use, is all I'm saying. Okay. So parental substance use and ACEs. So substance use alone, one of the things we caution about in research is substance use alone does not mean child abuse or neglect. There might be child abuse and neglect going on in a home, but parental substance use alone doesn't necessarily tell us whether that's going on. So what we do see is some states do have mandated reporter requirements about substance use, illicit substance use in the home, and that being labeled as child abuse or neglect. But as researchers, there's a consensus that this is a poor practice, that states should change those mandated reporter requirements to be mandatory only when there is suspicion of a child's emotional and physical injury resulting from the parent's substance use. The substance use alone is not enough to be sort of categorized as abuse or neglect. And we also need to recognize that there's harms to parents and children of child welfare system involvement and custody loss, and that needs to be weighed against the risks of harm from substance use. And separating families is part of the ACEs too. Separating families is a traumatic event. So yes, sometimes we have to weigh the traumas, right? But that needs to be carefully done. Sometimes people, like a drug test is not a parenting test, is one of the things that we say in this research all the time. That just because someone uses drugs does not mean they're abusing or neglecting their child. They might be, but so might a parent who's not using drugs, right? Okay, and then when we're thinking about drug use nationally and in Michigan, we do have a significant public health drug crisis going on in this country. I don't want to underemphasize how dangerous drugs can be in this country. And in Michigan, we see that, drug overdose deaths are rising. This is only through 2021, but the rates have also gone up in 2022. We don't have 2023 data yet, unfortunately. So what we see is that for Michigan, most of these drug overdose deaths are being fueled by opioids. That's why these two lines are following each other. The pink line is opioids, the red line is all drugs. So all drugs would include alcohol, methamphetamine, benzodiazepines, all sorts of other types of drugs. But opioids are responsible for the vast majority of these deaths. And we look pretty similar to the national trends. The blue lines are the national drug overdose deaths. And the darker blue line is due to opioids. We are slightly above the U.S. rate for overdose deaths due to opioids, a little above the total sort of drug overdose death rate. So we're sort of doing the same as the rest of the country, but how we're doing is not well, right? This is not a good trend. We do not want to see any public health negative outcome going up, and that's what we're seeing. When we're talking about the types of opioids involved in overdose, so what is an opioid? It's heroin, it's prescription painkillers. Not all prescription painkillers are opioids, but a lot of them are. It is street drugs like fentanyl. Not every type of opioid is really fueling what's going on right now. What you can see is like in the early 2000s, kind of each type of drug was contributing a little bit to a lower overall death rate. What we see as of 2015, that red line is shooting up. What's that red line? It's a class of opioids called synthetic opioids, which we typically refer to colloquially as fentanyl, but fentanyl is one of a few types of synthetic opioids. What this means is that the main driver of our overdose deaths now is not prescription opioids. That's the blue line. You can see that one it kind of went up in 2012, and it's kind of like a little bit up and down, mostly flat though. We actually prescribe prescription opioids now at the same rates we were prescribing them in the mid-90s. So we do not have this sort of like pill mill prescription opioid crisis anymore. What we have is an illicit opioid crisis right now that is being fueled by synthetic opioids sold in the illicit market. So things like fentanyl, carfentanil, that's what's driving our overdoses. You can see even heroin, which is an illicit opioid, rose a little bit around 2014 to 2017, but that's not even what you're buying anymore on the street. What you're buying is synthetic, cheaper to manufacture opioids like fentanyl. Methadone is a treatment medication that sometimes can cause overdose, but you can see that pink line is flat. So we really are not worried about methadone contributing to overdose. What we're worried about a little bit with heroin, not so much anymore, but we're really worried about these synthetic opioids. We are not worried about prescription opioids. Prescription opioid prescribing is very low across the country, Michigan included. And when we think about sort of regional differences, what we see is some people think, well, that's not happening here. That's not happening in my community or my county. It is happening across Michigan. You can see even Oakland County in the center there, which has relatively low rates of opioid overdose death, has experienced a rise over time. From 2016 to 21, we see their death rate increase, right? We can see Wayne County has the highest numbers. Sometimes people have asked me, well, why is Oakland so low and Wayne County so high? And one of the things that we've heard is that people, when they're using drugs, come to Detroit. They're from these other counties, but they're coming to Detroit to access drug markets, to access services, and there's reasons that they're coming. They're not necessarily from here. They're not necessarily from Wayne County, Detroit area. So it's people traveling in from these outside areas. It's not that those outside areas those other counties don't have a problem. They all do, right? Did you want to add to this?
Right, yes, because that absolutely is something that we experience a lot on the SSP vans, like on the syringe service van in Detroit. We have a lot of people that are not from Detroit, even from other areas in the United States that come here throughout their experience of being unhoused and using substances. Their journey just kind of led them to the city. But I think what contributes way beyond that, right, like what the handful of people that I might see every month that aren't from Detroit that are using drugs in Detroit that may pass away within the city limits is racism. So this is a clear demographic, like a graph, right, that like clearly shows the disparities in a black like a community that's predominantly black. Because if we broke Wayne County down, Detroit would be the overdose death rates, and we're looking at Oakland County. Now, I'm a person that used to use drugs, and I used to buy my heroin in Oakland County, right? And there was a period of time where I would use in Oakland County, but for the most part, I'm born and raised in Detroit. I still live in Detroit, so I used a lot of drugs in the city of Detroit. But this, I think we need to really take a look at how this kind of proves those disparities and negative health outcomes that we're looking at when race and money and resources are involved. Because Oakland County has that low graph because the people living in Oakland County that are using substances are not unhoused, and they're not hungry, and they're not having to do things like rob or make decisions that they would not make if they were not struggling with substance use in order to be able to use and take care of their basic needs. The people in Oakland County have access to resources. The drug users there might have wealthier parents. I mean, we're looking at Oakland County is one of the wealthiest counties in America. So those deaths are so much lower, not because rich folks don't use substances, but because white folks that have access to resources can use substances and still maintain a life.
Yeah, that's a really important point. These are not addiction rates. These are death rates. So these are like the worst possible outcome. You had the riskiest use. Where are the people dying? Not where they're from. So how we count deaths is where someone died. It's not where they're from, it's not where they live, it's where they died. So yeah, she's also pointing out that this doesn't reflect where addiction occurs most. We don't have those data from the CDC. I wish we did. That would be very helpful. We have where people died. Those are the easiest data to get because, the police and EMTs and the hospitals all help us record them. It's harder to get an estimate of addiction because we need to ask people who are alive, and not everyone wants to disclose that information. So, I also want to point out the sort of because we're talking about parents, right? That pregnancy and overdose have a really disturbing relationship. One of the riskiest periods for someone's overdose risk is right after having a child. This is actually one of the top reasons that pregnant people die is actually that's not related to their pregnancy is actually substance use disorder. So these are data from the Michigan State Department of Health from 2015 to 2019. And these are the reasons why pregnant people die. They're not related to their pregnancy. The top reason is substance use disorder. So what that means is overdose. And that Michigan is sort of, we're not doing that well with this population. So nationally, about 16% of deaths among U.S. pregnant people between 2017 and 2020 were overdose related. There's been an increase nationally in this going on, an 81% increase, which is a very high rate of increase. And then Michigan, we have the same trend. For a different time period, though, it has been about 40% of our maternal deaths while someone is pregnant, and that's really high. Do you want to talk about any of the some of the risk factors for why I can't? Why is this going on? Do you want to say any of the reasons why? Okay.
Well, because folks that are gestational, right? Folks that are pregnant and using substances are not accessing services and are higher risk of overdose being kind of a result of their drug use. For a few reasons. One of them, I think, in my personal experience, but also the experience of a lot of people that receive services from me, and I've gone through maybe 10 to 12 full-term pregnancies with clients that are receiving syringes with me that never received any prenatal care, and the reason they all gave me was the same. It was because of medical abuse that they experienced in the past. It was because of having social workers that did not support them and stigmatized against them. It was because of experienced racism within the healthcare system. It was because of the experience of having to deal with the criminal justice system while pregnant. Some of these women had already given birth within a prison or another kind of difficult circumstance, and they just were not the mental capacity to have to relive that is not something that a substance user is readily available to do, especially one that's already living in the trauma of being separated from the children they've already had and currently pregnant again. So they're just not receiving prenatal care. They're also feeling a lot of shame. I noticed too that when my clients started showing, they stopped coming out to the van. They would send someone else random that doesn't use a sibling, and I would call and say, I wanted to see you. I wanted to use the Doppler. I wanted to hear the heartbeat. I wanted to make sure you're okay. I do not care if you go into labor on my van. I will still provide you with all the services that you need to be healthy and to make sure that you and this baby come out okay, right? Because drug use is not a measuring stick for parenting, and I also do not use drug use as a measuring stick to worthiness. And it's something I have to remind folks, continue to come outside and continue to get resources even after you're showing. But that's what happens. They stop, so they're not getting Narcan. The shame stops them from using in front of people. That's actually something that I did when I was pregnant and using. Once I started showing, I just stopped using where anyone else was. So I put myself at extreme risk because I was only ever using alone, and you cannot Narcan yourself, although Narcan was not available the last time I was pregnant. That in my experience. I don't know if there's...
That's right. Yeah, that's right. And it also, especially this idea of once you're showing, you get extra judgment as someone who's showing. We do have evidence-based treatments, so we're going to go over what those treatments are, but you get judged for using the treatments for addressing your opioid use, not just for continuing use. So it's you're damned if you're doing, you're damned if you don't. You're sort of judged no matter what you do. So a lot of people just continue their illicit use, which is the worst possible outcome because it's the riskiest. So we have treatments that work, but people are judged for using them, especially pregnant people, and we'll talk about why that is. So that's what's going on too.
Sorry, Erin, because what I wanted to say a couple graphs ago was remember that graph, because when we come back to evidence-based practices that are used in pregnant folks like methadone, I want to refer back to that graph because it's so stigmatized against and viewed as such a negative choice to make for your health care, and it's still so highly regulated and inaccessible because of the stigma, but it's not causing harm.
Yes.
So I want you to remember that graph and how insignificant methadone is when we look at the negative impact it has, yet it is something that every pregnant person that gets put on methadone experiences is bias, stigma, and discrimination for using MOUDs while pregnant, even though we also know that these MOUDs are not what's out here killing folks.
Yeah. So one of the things that happens a lot is pregnant people get sent to detox. That is not an evidence-based practice. Pregnant people should not be sent to detox. It is not the standard of care. They should not be told to get off opioids. It's extremely risky, actually, for them to get off opioids in the pregnancy or postpartum period. So we'll talk about what the alternatives are in a minute, but again, detox is not the standard of care. People should not be urged to stop their opioid use, that there's safer ways of using drugs, include treatment medications that have the best possible outcomes. We cannot help a parent who's dead, right? Oh, I'm gonna cry. I'm pregnant, so you hear a lot about parents getting shamed for the types of treatment that they're in, but treatment is the best possible outcome. The idea that they'd be the safest if they stop using is a fantasy, that people are at higher risk for dying and you can't save.
Aww.
I'm very emotional.
Yes, I know. Well, I know because I've been pregnant, but also just because this topic like is so meaningful and it's like it's caused so much harm and unnecessary deaths. The other thing I wanted to add to what Erin was just saying too, is this idea is reminding folks. Right, like me and Erin aren't coming out of like left field because I get talked to it like that about like people talk to me like I'm just coming out of left field with some like super radical ideals, and the last time I gave birth was almost 10 years ago, and of my 4 kids, and my OB at the time practiced this for me. Like, she practiced that I was not to leave there and just not get high, that I was pregnant, that we needed to run some tests, that there was things that we needed to figure out, and just to sit down and continue to live life, because as of that day, babies were good. I had a multiple gestational pregnancy, so babies were good, I was good. So just stay the same, do what you're doing, let me draw your blood. So like these practices, like there are providers that are offering this care, and they're like one in very, very few, and they also face stigma within their workplace for like offering that type of space to allow me to even exist in as a drug user. So just remember that this isn't some new idea. We've known for a long time that these things work better than the expectation of abstinence or the stigma against methadone, or just accepting that pregnant people will die of overdoses because they deserved to because they were on substances. This has been around. 10 years ago, my OB encouraged me to continue to do the things that I was doing so that me and the babies inside of me had the best possible outcome. Because for her, it wasn't about whether or not I was a good person or even worthy of being a parent, or drug use wasn't even like a thing that came. It was like I was a drug user. So it wasn't like an extra conversation that me and her had to have. It was just who I was. So as a drug user, you're going to leave here and you're going to do what you do, and I'm going to run these tests, and I'm going to see you in a couple days. And like that was important, and that was meaningful, right? That changed the outcome of that pregnancy. And like once we get into that pregnancy later in this training, you'll understand more. But there was a lot of risk, and she prioritized reducing as many of those risks for me as possible, knowing that it was unlikely if she just like shamed me or judged me or made me feel badly or like deeply encouraged me to stop using that day, that would not have been risk reduction. And she identified that and reduced my risk as much as she can in the situation that I was in.
Yeah.
Like just like the lack of support in like the pregnant person's life, is that kind of what you're referencing to? So when we look at substance use and how it affects dynamics within a home or in like a romantic relationship, it's almost, I don't want to say it's inevitable because there's no data to prove it, but it's kind of what do you call it? A sacrifice to the lifestyle. In that lifestyle, it is just kind of how we react to really big things like pregnancy is like we dip, and we cannot support this situation in the way that it's happening right now. For the folks that I've dealt with that were pregnant, who did not have family support, who baby's father was not around most often, my clients didn't really even know the paternity of their baby, and like this was another thing that we kind of had to overcome, an intersection of adversity that we had to overcome. But when those things are happening, I did have 2 married couples that were drug users that had babies while I was their social worker. Those men did not leave, but I can tell you in that experience that seeing those men stay and support their drug-using pregnant partner changed drastically how I think those pregnancies would have gone, because both of those women had healthy babies, both of those women maintained the housing that they were in when they were pregnant, and it did look like, so I like that you brought that up, because it did look drastically different than the pregnant users that I knew that weren't getting support.
Yeah.
You know?
Social support is one of the most important protective factors. So yeah, if a partner can stay and it's a, not an abusive relationship, that is ideal. But yeah, that's not the situation, unfortunately, for everyone. Okay, so we'll come back to pregnancy throughout this presentation. I wanted to bring up probably something that you've heard about a little bit in the news, which is there's a new contaminant. So our drug supply in the United States is largely, what people are using is largely an illicit supply. So again, we're not seeing people getting, diverted prescription opioid painkillers. That's not going on anymore. What you're getting is illicitly manufactured opioid painkillers that are made to look like they're real prescriptions, or you're getting heroin or fentanyl right on the street. Because the supply is not regulated, the way we regulate alcohol, right? That means sort of illicit labs are making these drugs. One of the things that they've started to do is to add this new ingredient, which is called xylazine, or on the street it's called Tranq. This is a non-opioid veterinary tranquilizer that's sometimes added to illicit opioids to lengthen the euphoric effects of opioids. So there's sort of like a reason to do it. It's not like an accident that it's in there necessarily. But the problem with Tranq, the problem with xylazine being added to opioids is that it increases overdose risk. So overdoses involving opioids and xylazine can still respond to naloxone, or also called Narcan. But overdoses that are primarily driven by that tranquilizer piece will not respond to naloxone or Narcan, because that's only something that works on the opioid piece of the drug they took. And this is not an opioid, it's a tranquilizer, which is a different type of drug. Also, chronic use has been shown to be associated with pretty bad wounds. Skin abscesses, soft tissue infections, even at sites not used for injection, and even among people who are smoking or snorting their drugs are getting these wounds, which is a really new thing. We typically only think of wounds as occurring among people who inject. That's not the case if they're using what's called Tranq dope, so opioids that have xylazine in it.
So about a year and a half ago, we started doing data analysis on the drugs that we would seize within the city of Detroit. Now, I'm an abolisher, and I do not partner with any law enforcement. But what I would do is I would take this data analysis that they would do, and they would run drugs that they seized through chemical lab analysis. And around a year and a half ago, we started getting our first several data analysis pieces that were showing xylazine in the heroin supply in Southwest Detroit. Okay, so we started seeing it, and we started preparing. Like in the syringe service world in Detroit, we knew that once we started seeing it in Southwest, it was going to start kind of funneling in to the inner city, to the north end, to the east side. So we prepared our clients for this. The substance supply coming in is testing positive for xylazine. This is increase in wound care. In the last year, my job has been primarily saving people from dying of preventable wounds. I've had several clients pass away in the last 12 months of nothing related to overdose, but related to sepsis or long-term infections that weren't being treated and passing away as a result of that because they're not accessing care because they can't, kind of why we're doing this here today. And the other part with the xylazine, or kind of like the data analysis situation, is just remembering that our drug supply in America is poisoned. I have looked at data analysis of lab reports of seized drugs from all over, and it is xylazine, fentanyl is affecting all of the drug supplies within the United States, and it is the first time since we started recording around the 80s crack epidemic, early 90s is when we had our first fentanyl crisis, and around that time we started keeping track of the different cutting agents that we were seeing in these drugs, right? And this is the first time since we started keeping track that the cutting agents were more deadly than the substance. So we're looking at a flip of power between the drugs, right? It used to be the heroin was the power, and the cutting agent would be, I remember back when I was using, a lot of times it was dietary supplements, vitamins, laxatives, things that have a drowsiness effect like Benadryl to kind of enhance the drowsiness that these downers give you without it being significantly more dangerous. Like you're injecting some hydroxyzine, antihistamine with your heroin, right? So you're getting drowsy, you're thinking you're more high than you really are because it's just the Benadryl kind of increasing the effects of the heroin. But now our cutting agents in all drug classes, not just opiates, are more dangerous than the drugs themselves. So we're starting to train people how to safely handle xylazine and fentanyl when these trainings used to really focus on uppers and stimulants and methamphetamine, because it was not something we were experiencing before. Our drug supply is poisoned. Every single drug needs to be tested for fentanyl. I've had several clients die that are not opiate users, and they have died of fentanyl overdoses. I've also had clients that identify as heroin addicts that will test negative for heroin and positive for fentanyl because the heroin is actually pure fentanyl. And I'm seeing that a lot in like the 48230 zip code, like Palmer Park, Highland Park, North End. For those of you that work kind of within this city, that's the trend I'm seeing kind of in like centralized city proper. But that's overall kind of what this field is really struggling with, is how we overcome when the drug supply has cutting agents that are worse for the population than the drugs.
Yeah, and some people have sort of asked, like, well, why is there fentanyl and methamphetamines and crack and cocaine? We think it's by accident. We think that, when we're talking about an illicit drug manufacturing operation, they're dealing with multiple substances. You're not just producing crack and cocaine. So there's some contamination that's happening, and that's why it's in the methamphetamine and crack and cocaine supplies, because people actually don't want their customers to die, because then it's not a customer anymore. So we think that this is by accident, largely. And then, of course, when we're trying to get heroin, you're getting fentanyl instead. The reason that's going on is because fentanyl is cheaper to produce than pure heroin. Okay, and so in Michigan, we do have a growing xylazine problem. MDHHS gave us these data. We have initial data that shows that the cases are rising. These are the deaths in Michigan involving xylazine. So 60 in 2021, 92 cases in 2022, and then in 2023, we have 270 as of April, so not even halfway through the year, and 100% of those involve fentanyl too. So we absolutely have this problem here. You'll see it sometimes referred to in the news as this is like a zombie drug. I don't think that's particularly helpful as a way to talk about it, because it kind of dehumanizes the people who are using drugs. It is a downer, right? It is going to make you more sleepy or maybe feel a little more high. But they're still people. They're not zombies. But the take-home message here, what these data show us, and what Bree is sort of alluding to when she's saying a poison drug supply, is that substance use happens here in southeastern Michigan. It is a public health crisis. We have a public health crisis related to a poisoned, illicit drug supply, and our current strategies are failing. Those overdose death rates are just going up and up and up. Right? They're not getting better. So we are not doing what we need to do to turn the curve around. And so people like me and Bree are advocating for some strategies that do work, that are science-backed and have worked in other countries. And so we're going to be talking about those today. But one of the main barriers to both those interventions and sort of addressing better people who use drugs is stigma, right? So we're going to say a little bit about stigma, and then Bree's going to tell her story. So when we talk about stigma, maybe one of the most important steps that any of us can take is changing our language. So stigmatizing language matters. We don't have a million studies on the effects of stigmatizing language, but we have a few that are pretty good. So the terminology for substance use does affect how we sort of perceive patients or clients and their care. So for example, there's this sort of old study, there's newer ones too, but a 2010 study of 500 plus mental health professionals sort of had them look at two vignettes or little narratives. One called a person a substance abuser, and the other called the person a person with a substance use disorder. That language change actually mattered. The vignettes that people responded to, where the individual was referred to as a substance abuser, meant that the sort of person taking the survey agreed more with punitive responses like jail to the same scenario, compared to when that same person was referred to as someone with a substance use disorder. So our language matters. We need to be careful in how we talk about these individuals, because it patterns the responses and how we treat them as well. So we have updated terminology. We do not see this terminology always being used, in news reports, even among clinicians in my department, family medicine doctors, right? I hear them using the old terminology, and I always try to gently prod them to use the new terminology, but it's a hard shift. It's something that we need to work on. Sometimes I even catch myself using the wrong terminology. But old terminology would be things like substance abuse. Now we say substance use. The reason why: abuse is the mistreatment of a living thing, elders, right? Pets, children, right? You can't necessarily abuse a drug. You might be harming yourself a little bit in that process, but it's just not the same as real types of abuse that harm a living being. Also, when we're talking about maybe like syringes or people referring them as clean or dirty, or like a failed drug screen, using more neutral like clinical language like used or unused for needles, sterile, unsterile, or for a drug test, substance use or substance free, right? Saying someone failed a drug test is a little stigmatizing. Even actually sometimes referring to relapse as relapse sometimes feels a little stigmatizing because we don't refer to other chronic conditions as having relapse. We refer to them as having recurrence in medicine. So we try to use that if we're in a clinical situation, or more colloquially, we'll say something like return to use, because relapse just has such a negative connotation to it. We also talk sometimes about patients going to different doctors, trying to get different types of drugs. We refer to that sort of negatively as doctor shopping or drug-seeking behavior. We talk about a lot in the medical community. But I do not like those types of terminology. What people are seeking a lot of times is relief from their substance use disorder, relief from chronic pain, right? Sometimes they're just getting a second opinion because they think that opioids are the intervention for them. There are some types of chronic pain that are responsive to long-term opioid treatment. It's not true that every type of pain can be solved with a non-opioid drug. That is not the case, okay? So sometimes people have a strong perception of what they think would work for them, and they're looking for a doctor who maybe is responsive to them. I also just tell people in your documentation, whether that's medical documentation or otherwise, using descriptive language is always the best. So patient or client has seen multiple providers, patient has chronic unmanaged pain, as opposed to person is a doctor shopper, person is drug seeking, right? That sort of primes the person reading your notes, the next clinician, the next social worker, to have this negative perception of what that patient or client's doing. When we're talking about diagnoses, we've sort of already gone over this. We still say addiction. Addiction is fine. Some people think it's a little stigmatizing, but I tend to still use it because it's what people understand, right? But we tend to not say anymore drug dependence or drug abuse because those used to be actually diagnoses. They no longer are. We haven't used those in many years. So now we say a substance use disorder. We don't differentiate between abuse or dependence, and we could specify the type, so like an opioid use disorder or an alcohol use disorder. We also don't say drug habit or problem. It kind of trivializes it. It is a diagnosis, right? It is a clinical condition. When we talk about individuals, we try not to say things like addicts, alcoholics, abusers, or users, though of course sometimes we do use those languages to slip up, or sometimes people refer to themselves like that, and Bree will talk about that. But as clinicians or people working with this population, we try to use person-first language, saying people who use drugs, because they're so often dehumanized that it can feel really non-judgmental, and it can help the patient engage or client engage better to actually be referred to as a person first, as opposed to a drug abuser or user. Who would have thought? And most important for this presentation, when we're talking about babies born to parents who use drugs, a lot of times people refer to infants as addicted to drugs. That's impossible. Infants, children, cannot be addicted to drugs. We say a newborn exposed to substances, a baby with signs of withdrawal from prenatal drug exposure, or a baby, if we're talking about the actual diagnoses, we have two. So baby with neonatal abstinence syndrome, or NAS, or if we know that it was opioids that they're withdrawing from, because there could be other drugs they're withdrawing from, we say neonatal opioid withdrawal syndrome, or NOWS. Sometimes people sort of talk about addicted babies, right, when they're referring to these, but again, they wouldn't meet those social criteria of addiction where they're not meeting their work responsibilities, right, or something. They can't be addicted to drugs. They can be physically dependent, and that's it. Treatment, so we're going to talk a lot about treatment today, but in the past we referred to medication treatment as medication-assisted treatment. You'll still hear people use that a lot. It's not necessarily that stigmatizing to say that, but one of the reasons we don't like that terminology anymore, and we prefer medications for addiction treatment to mean MAT, is that the assisted implies that the medication is assisting talk therapy. Talk therapy is great for some people. Some people absolutely benefit from that who have addictions. Some people don't, though, and the medications alone are treatment. They're not necessarily assisting anything. They themselves are treatment. We also can talk about specific types of medications for specific addictions. So we can say medications for opioid use disorder or alcohol use disorder. We can say medications for substance use disorder if we want to say for all of them. We also tend to not say replacement therapy or opioid substitution therapy anymore because that sort of equates illicit drug use with the medication treatment, and we're trying not to do that. We might say opioid agonist therapy or pharmacotherapy. We'll talk about what all those drugs are in a little bit. And then when we're talking about people in treatment or recovery, we try not to say being clean, right? If we're in a professional environment and we're talking to a client or patient, because again, there's like that clean, dirty dichotomy. No one wants to be referred to as dirty. right? So if they're not clean, does that mean they're dirty? That doesn't feel very good to be labeled that way. So we say, maybe use like the more clinical language, like being in remission, or being in recovery, or being abstinent from drugs, but recovery and abstinence mean different things to different people. For some people, that means I don't use any mind-altering substances at all, maybe not even caffeine, maybe not even tobacco, right? For other people, it means I don't use the drug that I had a problem with, but I maybe drink alcohol or I smoke weed, right? So there's different definitions of that, and there's no single definition of abstinence that we use in science, actually, either. We have different definitions for different types of studies. So sometimes a lot of times when I give this talk, people ask about, well, what about when people who use drugs refer to themselves as addicts, right? That this is something, especially people in AA and NA talk about a lot. I was going to have Bree say something about it, but she's leaving. Okay. Okay. We'll come back to this. Okay. So we'll come back to this idea, and Bree will kind of talk about this as a person who does identify as someone in recovery. So I'll come back to it. So stigma, when we're talking about stigma is not just a language thing. Language is probably the easiest thing for us to fix, but stigma is a really complex process. Stigma happens at multiple levels in society. So at the lowest level, stigma can sort of be internalized by people who use drugs and sort of like self-hate and shame and guilt and stuff. At the middle levels, though, that's sort of like where we're all operating, which is stigma towards people in our social networks, stigma from doctors and social workers, us in the professional community. We can be stigmatizers. And at the higher levels, there's also sort of stigma in the general public, what's called structural stigma, so stigma through laws and policies, hospital or clinic rules, or government and agency policies. So I'm going to go through some examples of each of these. So we just talked about the language one. That one can be sort of throughout these levels, right? Being called a junkie or an addict, we can do that to ourselves. We can do that to other people. We can do that in a professional environment. The public does that, right? So we can see that happening a lot. This idea that, people who use drugs are not good parents can be happening at the provider level. So that means not just healthcare provider, but any sort of professional who's working with this population would be in that provider category. That assumption is sort of a type of stigma, and also the public has that idea too, right? That people who use drugs are never good parents. At that provider professional level, we see this in medicine a lot, only focusing on substance use and overlooking sort of other health, housing, or resource issues, and sort of saying, well, we're not going to help you unless you stop using drugs. That is a type of stigma, because that is also not an evidence-based practice. It actually doesn't get us what we want from that individual. We'll talk about other sort of strategies. And then sort of rehabs. Inpatient treatment facilities are very frequently across the U.S. denying care to patients who are treated with the standard of care medications that are used to treat opioid addiction, which are methadone or buprenorphine, sometimes referred to as Suboxone. And we allow that in this country, which is shocking sometimes in other countries, that we say, hey, the standard of care, the gold standard treatment for your addiction, you're not allowed to have it if you want to come to this rehab facility. That happens across the country, happens in Texas, New Mexico, Wisconsin, here, right? These are all the places I've lived and done this research. So those are types of sort of provider-based stigma. Also laws criminalizing drug use instead of treating it as a health issue. We in the addiction field feel like that's a type of structural stigma, right? We have been going on, 50 plus years with the drug war. It has not worked for us, right? We see overdose rates going up and up and up, and we just say, let's put more money towards, stopping the supply, penalizing people who are using drugs, and it's just not working, okay? So that is a type of structural stigma through laws, but also like investing more money in law enforcement and incarceration's responses to drug use and public health. They get most of the money that we have for addressing substance use. A lot of these opioid settlement funds are going to law enforcement agencies, not to treatment programs, not to harm reduction programs. They're going to law enforcement. The people who are what we call in public health the tertiary responders, they're coming on the tail end. They're not doing prevention work, right? That's what we all are supposed to be doing at MD, HHS, and the universities, and harm reduction programs like Bree works in, which is not to say give them zero money, that let drug dealers do whatever they want, right? But we're not putting our money in what we know works from science, and that's a problem. Also state laws that report parents treated with substance use disorders to child welfare services. NPR just had a wonderful story, and the New York Times had sort of like a print piece about it, that sometimes parents who are treated with the standard of care medications are actually reported they're not using drugs, they're being treated with a medication to treat their opioid addiction, are sometimes reported to child welfare services for the use of that medication as indicating a past substance use disorder. Some state laws require that reporting. So they don't have a current addiction, they're being treated for their addiction. Maybe they haven't used illicit drugs in years. Sometimes they still have a child welfare services case opened on them. Sometimes their children are still removed. So that would be an example of state laws and sort of provider-based stigma as well. What we see sometimes in the healthcare space too is covert urine drug screening to detect illicit substance use among pregnant patients in particular. So Bree can speak to this too, that this happens to her clients a lot, that they're not being told that part of what their urinalysis is being used for is to detect drugs. And also the mark of sort of past child welfare cases can follow subsequent pregnancies. So Bree can speak to this as well, that in some states, a past child welfare case, even if that case has been closed, any subsequent pregnancy will open a new one for you. Even if you've been in recovery, right, abstinent for a decade, right, that can still happen. Yeah. So Bree can speak to this because she has had this problem personally. She just came back. My understanding is it is still here, but that's actually a question we have for you all who maybe are doing some of this work in the field. Is this something that's going on? So Bree, what we're talking about now is the covert urine drug screening, but also this sort of the mark of the past child welfare cases following people. So in Michigan, do we still have that go on? As far as you know?
Yeah, so kind of how the policy goes, an individual, and this is one of the issues with policy and law, is when we don't have regulation as to like the maximum or minimums that we can do to a person, we leave it up to people, humans with bias and stigma and discrimination to decide which policies that they want to bring into the organization, right? Excuse me. So in hospitals, in the state of Michigan, we have the CPS child welfare system. And in hospitals, one of the mandates across the board is that if your baby tests positive for drugs at birth, CPS gets called. That is a given. Nobody has a choice. Everyone that is a mandatory reporter in that hospital, which is just about every staff member, has to report a child being born while testing positive for substances. Now that the other policies are kind of the ones that they get to cherry pick. So another policy that exists and is very prevalent within hospitals in the state of Michigan is that if you have given birth and lost custody of your child because it tested positive for drugs, and you did not receive custody of that child back, right? You did not successfully reunify with that child. Maybe you continued to use substances. Maybe you didn't. Maybe other circumstances were at play. If you never receive reunification and you go to have another baby, you are then red flagged in the child welfare system. And regardless of the drug test of that baby, CPS is coming. CPS was in the room of my last birth before I got out of recovery for a C-section, before they could have possibly tested any of the babies, and prior to having even a conversation with me. So I am in the system as a red flag. I'm a person that had not reunified with the first baby that I had given birth to at the time. My sister also had the same experience, although I'm going to bring her experience up because it's slightly different in the way that I was still using substances that last time I gave birth. So CPS was likely coming either way, but they originally called because I'm already a red flagged person. My sister, on the other hand, had a very different experience where she gave birth to my nephew 15 years ago and lost custody of him when he was 1. He was then adopted by people that we don't know. My sister was also a heroin addict. And 13 years later, my sister, long sobriety, she has gotten married at this point. Her husband and her opened up an auto shop, successful. They have a beautiful house on Adams in Oakland County with a pool. She gets pregnant with what is now my niece and nephew twins. And CPS was there when she gave birth because she had this 13 or 15-year-old history case of having tested positive for drugs at birth and not reunifying with that child. So my sister, in a radically different place in her life, still had to defend the drug use of 15 years ago to CPS agents, who then kept her on house checks for about 4 to 5 months prior to just permanently closing that case. So for 4 to 5 months, my successful, sober, sister who just had no reason to have to explain their ability to parent. And what else happens in these different like stigma markers and the things that they use for past drug use with children is other things come into play. So I hate the NAS and the NOWS diagnostics because my kids' medical history forever says NOWS. Like they have neonatal opiate withdrawal syndrome. It will be in their medical records forever. So guess what? Forever I face. Forever when my children receive health care. Forever when we have to go for emergencies. Forever when what they consider questionable injuries happen. I'm a parent bringing my children in for care, and it is in their history that they were born addicted to drugs. Okay? And it's in my history that I gave birth while using, and like stigma starts at intake. I promise you, the moment that somebody opens up my medical records or the medical records of my children where NAS and NOWS are written, it's immediate. All of a sudden, they have all of these policies that they have to abide by, and the current situation, so last April, I tried to get some of my criminal record expunged. And on my criminal record is substance using parent. I can show you the paperwork. That is a thing that they will put.
Did it run out of batteries?
I don't know.
Oh, there
No.
it goes.
I told you. You didn't believe me earlier when it stopped working. You guys looked at me like I didn't know what I was doing. And, so in April, I try to get these things expunged because the substance using parent thing on my record affects like what people can grant me for certain things, right? And what population I can serve. I cannot serve anyone under 18 because of this criminal record. And I am over a decade sober. I'm a professional. I've owned 2 homes since I got sober. I have gone to college. I have 4 children. I regained custody of all my kids back. And they denied me expungement because I was a liability to any future children I might have. And that is in my court transcripts, you guys. So, like, this is a real thing. Like, this will follow me. If I get pregnant, if me and my wife decide to have a baby again, like, we have to, the conversation, like, my next birth plan will have to include when CPS shows up. Like, a given. Like me and my wife would need to have that conversation as to what our plan of action is when we have strangers in our home nitpicking. And the last thing I'll say is that once you are in the CPS system or in hospital systems as somebody that uses substances, you are now held to a higher standard. Other moms that aren't using drugs do not have to prove anything when they give birth. They push the baby out and leave. And nobody comes and makes sure that when they get home there's a car or a car seat or a crib or food or water. Nobody is coming home with you to make sure your electricity's turned on. Those are all standards that now I have to prove as a person that has previously used substances while parenting. I'm held to a whole different standard of care and parenting than other parents. And I have resources now that plenty of parents don't have, who are not on the chopping block when they give birth, you know?
Yeah. So thinking about some of these policies, this is sort of more sort of examples of these policies that affect parents that we consider in addiction research to be pretty stigmatizing, which is like defining any substance use during pregnancy as child neglect. So several states do this, including Michigan in the past. My understanding is that since 2022 that's been changed. Adding parents who birth a child with that neonatal abstinence syndrome or neonatal withdrawal syndrome to child abuse registry. So South Carolina does that. Removing children from parents who do not complete court-mandated substance use treatment. Texas does that. That is a really problematic one because sometimes court-mandated treatment is actually not very good treatment. It's not always at standard of care places. It could be at places that are not very good at what they do. Most rehabs are actually not that great. Their outcomes are not very good. So removing children from a parent who doesn't want to finish treatment that's not working for them happens in no other area of medicine. I mean, this is really wild to me as someone who works at a medical school, that not finishing a course of treatment that maybe isn't a good fit for a patient would result in child removal. We don't have that law here in Michigan, but I'm just showing you that in some states, like, it's extremely punitive how we treat these parents.
So, and that's the thing with the policies and the cherry picking. So there isn't a law in Michigan stating any of these things. My children were all NAS and NOWS children, and I did not get put on registry for that. I am on registry now because of drug use that continued after I gave birth. But like the removing children from parents who don't complete drug mandated treatment are like one of those situations where an individualized court, like like its own entity, could say that if you are a person participating in our drug court program, one of the things we are going to mandate is that you finish a 60-day inpatient treatment center, and if you don't, here are the consequences that we can put on you. We can call CPS, we can send you to jail for X amount of days, we can fine you, and like that. Those are, so it might not be something that's like a law and standard of care, but it is being practiced. And the drug court situation that I went through for 2.5 years, it was very much like, it was a very clear understanding that if at any time I fell short of what the court expectation was, that immediately my custody case with my kids would be impacted.
Yeah, go ahead.
I literally wish I had enough time to explain the child mill that is the United States, but that is virtually the exact same experience I had, where they just continue to wait for babies to get popped out of me for them to take and sell to the highest bidder. Like, that is a real thing. That is what's happening. Yes.
Yeah, and I think, so you gave a really good example of sort of this removal of children happening for not being adherent, compliant, I don't like the word compliance, but with sort of like what someone's been mandated to do. And I think it's important to say that just because it's not a law doesn't mean it doesn't happen. And one of the things that we also see in research about these parents is that sometimes there's costs associated with their requirements. So sometimes people have to pay for their own urine drug screening. Well, we're talking about very marginalized, very low-income parents who sometimes can't afford the cost of their urine drug screening. That is not a cheap test. And so sometimes that's the noncompliance. You're just poor, and your children are taken away, even if actually the result of the screen isn't the problem. You just couldn't take it because you couldn't pay for it. Like, that, to me, is really not acceptable to be going on.
That is heavily practiced, and in a lot of court system is the like plan of action. That is just like when you get your probation documents, it is laid out in there because poverty is criminalized. Once it's another example of, like, it might not be in written law, but we all know that when poverty is a situation that an individual is dealing with, they are at higher risk of being arrested, of being harassed, of not getting proper health care, of not having access to resources, and of substance use disorder. So, and we've criminalized poverty, and that's why cash bails this. So this idea that when you're not complying with something that's court mandated, but they don't take into consideration any context of the circumstances that you're in. I was violated for not taking a drug test. Luckily, I had a parole officer who was in recovery and had like a room to give me grace, because it was also the winter. I was living in a shelter, could not get anywhere, and had no job. And I had taken over 1,000 drug tests on parole at this point and had passed all of them. And I missed one, and I got a warrant in my mailbox. Like I said, luckily my parole officer was like, let's do something. They had me do like a 2-day, some alternative to jail thing, a 2-day like learn about drugs course, but I had to pay for that violation either way. And I took over 1,000, and they were $30 a piece, and I had just gotten out of prison, and I had 4 kids. So like, do the math on your free time about how much I paid in drug testing fees and the expectation that parents and people that are already struggling with poverty, drug use, and intersectional adversity are already facing when they put something on our plate like daily or every other day drug tests that cost $10 to $30, and it's up to you to get there and figure it out. And drug testing facilities typically close around 9 a.m. They're open from like 5 a.m. to 9 a.m. So like that's your option as somebody that's struggling with all of these other things. Baby is to figure this thing out.
And then, of course, we can't sort of like ignore the ways that stigma towards drugs, right, and people who use drugs intersects all these other types of stigma. I mentioned earlier that racism is a type of stigma, like classism is a type of stigma, right? So stigma towards substance use can be amplified by these other stigmas. Of course, like people who use drugs are people of color, who are living with HIV, who have mental health issues, who are pregnant, right? That these all can amplify the stigma and really cause a lot of problems. And so we have a lot of actually good research on the intersections between substance use stigma and racism. So one example for parents is that Black patients, regardless of their substance use history, have a higher likelihood of being tested for drug use during their birth or delivery, even though Black patients do not use drugs at higher rates than white patients. And in fact, some types of drug use, like methamphetamine use and opioid use, are higher among white populations. So this is really like a way in which we're seeing sort of racism as a stigma and substance use stigma sort of intersecting and making, you know, it much worse for Black parents in particular. Bree, let's go back to the slide about the language, and because we hear a lot of times people refer to themselves as addicts, especially people who are engaged in Alcoholics Anonymous or Narcotics Anonymous self-help groups. Do you want to speak to this idea, like what you do in that case if you have a client who refers themselves that way?
Yeah, so I follow the guideline. I have to extend my parking meter. You know, Detroit be getting us for that parking meter. I feel like they like get a notification when a meter expires and they like hurry up and write the ticket. Yeah. So I had to do that real quick. So the thing is that autonomy and self-efficacy and teaching folks how to have a voice and how to use their own internal resources to advocate for their needs includes allowing people to self-identify, right? We don't just save that for sexuality or gender or other identifying markers. We allow folks to self-identify with the experiences that they're having. I'm not going to correct somebody if they refer to themselves as a fat person. I have friends that wanted to take ownership of the word fat. That is very common in the queer community that I exist in, that we embrace body positivity, so we name it, right? We name the thing. Like, this is my beautiful fat wife. Like, that is a thing, and we are doing it. I'm not going to correct anyone. Will I ever call a person fat? Absolutely not. Would that be a word that I use to describe myself when I'm in different, like, weight parts of my life, because like that's just what happens to our bodies? No, because I don't personally attach myself to that word, and that word has also been used to harm me. So that's not something I would use to self-identify. I would say that I'm thick or curvy or something else, or I've gained a few weight. You know, I got my winter fur. Like, I would say something like that. I'm not going to correct someone. It's the same thing with the addiction. Like, there's a lot of folks that I serve that I've had folks call themselves a junkie. It's definitely not as common as hearing folks identify themselves as addicts, but there has been times where people have used the word crackhead or junkie to describe their chaotic drug use, and it's not my place to correct that. Although I will say every time it happens, I do educate that terms have changed, and although those words have been used against you to cause harm, we no longer have to be attached to that language. So you can choose to identify as someone that uses substances or somebody with substance use disorder. It's an option, but if you feel connected to the word addict and you feel that that is like how you have lived and navigated life as a person using substances, then take ownership of that term. I think it's important for all oppressed groups of people or people that face heavy stigma to take ownership of the words that are used to abuse us, right? Because inherently the word junkie is just garbage, right? Like, we can look it up on Webster Dictionary. It was co-opted by people who don't like drug users, people that wanted to stigmatize drug users, people that wanted to see drug users locked up. And that word was co-opted. So I see and understand why users want to take that word back and create new meaning around it. I think it's empowering for oppressed communities, but I also think it's something that's very individualized, because I would also never use the word junkie or anything to describe myself.
Yeah, so in professional environments too, I think even we have, clinicians that I do research with who identify as people in recovery and have substance use disorders themselves, but they say, even though I, in AA meetings might refer to myself as an addict, when I'm in a clinical environment, we're talking about a professional environment, this is my job, I use professional language, right? I say person with a substance use disorder, people who use drugs, even if that's what I use in my outside of work life. Okay, so this is very small text, I apologize for that. Stigma is not just hurt feelings. Hurt feelings do matter, right? Hurt feelings can be traumatizing, stressful, but the effects of stigma are significant, and we have a lot of research showing that stigma is a big problem. So not only does it cause emotional distress, which we know stress is not healthy for the body, right? But we also know it worsens a bunch of other outcomes. So it worsens social conditions and resources. So we know things like laws that prohibit renting to people with, criminal backgrounds related to their substance use, right? That affects their ability to access housing, employment. So we, like I work in a medical school, we have laws about addiction among our clinicians. You have to go through a very intense process if you're a clinician who has a substance use disorder to regain your license, and some of the things they ask you to do are not evidence-based, and they're really time-consuming. So it can affect your employment, affects your access to education, things like federal loans to go to college. It also worsens our healthcare quality. So we know that patients who are stigmatized are less likely to use medication treatment for their opioid use disorder, even though that's the best possible intervention for them. We know that it contributes to what's called discharge against medical advice. That's when someone leaves an emergency department or inpatient department at a hospital before we're ready for them to leave. We want to treat their sepsis. We want to treat something else that's going on with them, but they're being stigmatized so much by the nurses and the doctors that they just leave before they're done with their treatment, and that might be fatal for them, or it might just lead to worse, more expensive outcomes. Both are bad. We also know that it means people avoid their prenatal care. The more stigmatized someone feels, the less likely they are to come in for prenatal visits. We also know it worsens patients' health outcomes and their behavioral outcomes. So we know that risk of neonatal abstinence syndrome is actually higher among infants who are born in states with punitive policies towards parents' substance use. So that I mean policies like those that require patients to go to mandated treatment if they're using substances while pregnant, or that open up a CPS case for them if they're pregnant and use drugs. We also know that not only do people avoid prenatal care, they also avoid the very thing we want them to do when they're stigmatized, which is go to treatment, right? This is the thing. I mean, some people are not ready for treatment. That is fine. We should not judge that. But ideally, right, the best way to reduce your risk of substance use is to engage in some evidence-based treatment, right? If we want to try to get someone to that level while stigmatizing them, that tough love approach isn't going to be something that gets them there, unfortunately. We also find that people who are living with HIV have worse adherence to their HIV medication if they feel stigmatized, and we also see people who report higher stigma have less consistent sterile syringe use. So all these outcomes that we want for people are worsened by us making them feel crappy about themselves. So this tough love stuff doesn't work. We have other approaches that do work, though. So I'm going to let Bree tell her story, and then we'll have a little bit of discussion and then a break. So why don't you take over?
Yeah, that sounds... No, I don't like standing behind podiums. I wanted that last slide, the last thing I really wanted... I had it in my brain, Erin, and then you made it disappear. Oh, another thing is, the ongoing stigma once you have like drug use as like a part of your permanent record in criminal justice, education, or healthcare. And it did change recently, but I've had, my oldest child is 12 and a half, so I've been a parent for a long time. And for like the first 10 years of being a parent, I could not get Medicaid, cash assistance, or food stamps or anything because I was a convicted drug felon. You are not allowed to access social services in some states when you have that. Michigan was a state with that law, and as far as I know, that is no longer the case. But I have not myself tried to get social services, and I am sure, I almost want to just out of like curiosity, I'm sure that even if that law isn't in place, there would still be maybe an extra hurdle that it is that I have to jump over. I know that I received rent assistance And because of that law, my grandma was actually the one that they had to write the check to. They couldn't even like give me the rent money. They had to write it to somebody who didn't have a criminal record, who then had to make sure that my rent was paid. So just, the barriers that they place on folks make it really hard to have positive outcomes. And then, we're all looked at by professionals and judges and whatever, police and doctors, like they just cannot believe that you didn't stop getting high. But you offered me no path to do different or to do better that was easy or even accessible to me. Okay, so we'll just go in to my story. So it's funny that it's Bree's story. So I talked about this a little bit yesterday. I practiced on some of my friends what I was going to say here today, which isn't something I always do because I public speak often, and I'm very comfortable in very, very big rooms and crowds. And I'm also very transparent about the experiences that I've had in life because I've done a lot of work around my healing and my trauma. Like this wasn't the case 8 years ago, 9 years ago, 10 years ago. These weren't conversations I was really able to participate in because I was still very much living in the consequences of my drug use, and it was very overwhelming for me. Even though 8 years ago I was sober, I was still dealing with not having housing because of drug use, not having insurance because of drug use, being on parole because of drug use. So I was still very much in it and couldn't really adequately put language around what I was experiencing and how traumatizing it was for me to like continuously having to defend myself, to defend my right to services, to defend my right to things that I consider human rights, and to defend my right to have access to them as a drug user. So these are new conversations, but I'm very transparent. My drug use started when I was in high school. I would say for a very, very short period of time, my drug use was normal, teenage, social drug use. It is just not my story that it stayed like that for a long period of time, and it is just not my story that that was ever my intentions around drug use. I was using drugs to self-medicate. I went to my first psych ward when I was 14. So there was other things happening when drugs were introduced to me that really just created like an environment where it took off a lot quicker than maybe we see in a lot of other users. So by the time I was 18, I was a daily crack user. And it was so, I look back sometimes and it's like there's almost no way that with 24 hours a day in 1 year, my life went from what it was to what it was when I was 18. So like my 17th year of life, I went from being like a state awarded and sought after point dancer, ballerina, doing like a lot of work in ballet and thinking that this was going to be something that took me somewhere away from the abuse and the chaos that I was experiencing at home. Like this was my escape. But I also had this thing where I was a self-harmer and was living with an eating disorder. So although substances weren't a part of my life at the time, these other two situations put me at higher risk for when those substances did get introduced to me. So when I used at the age of, at the end of my 16th year of life for the first time, it was very, very quick. And within a year, I was not dancing. I had been to jail a couple times. I had been to rehab for the first time. I graduated high school somewhere in there and was smoking crack. Like that's extreme, right? And that is not the case for drug users across the board. And I really want to make that like clear. And I usually leave out the fact that my first substance was marijuana because people like just focus on that, like the gateway drug idea, right? Like that is not what was happening for me. Me smoking weed in my friend's treehouse is not why I smoked crack on my 18th birthday, okay? Like I was smoking on my 18th birthday because for years leading up to that, I was experiencing trauma with lack of resources, and my family was all of those things on the ACEs, right? We lived in poverty. We relied on churches bringing us food. I'm one of 6 and there's 4 dads. My mom was a teen mom. Like I had this family dysfunction, this family history that really put me at risk of a lot of things. And then I lived in an environment where the epigenetics really kicked in for me, where not only was I genetically predisposed to a lot of different situations that maybe wouldn't have manifested if I was raised in a different home, but because the home I was in also exacerbated those symptoms, using was all I could find to relieve that. And so I consider my use, a lot of us that are drug users in the field, so not necessarily people just in the field that use clinical terms like substance use disorder, all of us at the harm reduction line that are previous drug users, say chaotic use. Okay, so when the chaotic use, that is like when these evidence-based interventions start making a difference. And I think at the time for me, there was no language around what that progression looked like from being like a 16-year-old smoking weed to what chaotic use looks like now. And I know that at a very young age, I was in chaotic use, and that isn't always the case. Sometimes it takes years for people's substance use to really start negatively impacting their life. But when your starting point is already under the line, I was kind of on my knees pretty quickly. So that's how drugs became a part of my life. And I got pregnant for the first time when I was 20. I went to rehab, and at the time, I was struggling with crack cocaine use and alcohol use. I would say those were the two substances that I was definitely using chaotically, and I was doing all 11 symptoms of drug use. I lived for 6 years straight. There was not a day where I did not hit all 11. Not a day. I was in chaotic, extreme drug use. And I'm saying that because of what then comes in my healthcare and how the outcomes of parenting have been for me, but also to recognize that that is not an uncommon ending to drug use. Like drugs like crack cocaine, methamphetamine and heroin and different prescription opiates have a really high chance of that drug use hitting that 6+ like extreme score, simply because of the legality around those drugs. Like you automatically are at risk because you're not even allowed to be doing what you're doing. So all of a sudden, the arrest and the negative healthcare outcomes, all of that stuff starts coming into place. So every single day I was checking off all 11 of those boxes, 100%, checking them hard. I was doing things I would never do if I had not needed substances. I was doing things I wouldn't need to do if I had access to any type of resources. I used heavily and longer than I ever anticipated. I lived for 5 years straight in constant fear of feeling withdrawal symptoms because the detoxes that I did experience when I would go to jail or something like that were awful, and I would have rather died. I lived in this constant fear and constant space of having to brace myself for detox, withdrawal, arrest, CPS, like just constantly having to brace myself because I was fully immersed in all 11 of the symptoms of substance use disorder. So I go to rehab when I was 20, and this rehab I'm very familiar with all the rehabs in the state of Michigan because of the field of work I'm in, also because I've been to 8 of them. This one is probably one that I like the most in terms of like what I see that they're doing there evidence-based wise. I do think it's shitty they don't let people smoke there, right? I'm like, that's weird because we're like way past cigarettes over here, you know? So like, it's like some of those things where I'm just like, that's such an easy correction for a rehab to make. Like, let them smoke. Why is that the thing you want them to have to deal with when they're in detox? You know, but I went to this rehab and during intake, so it's very common. I've worked in inpatient treatment centers, and just about every single person that comes to intake gets high one more time in the bathroom, right? Before they walk through the threshold of the door to the detox wing, they say, 1 second, I gotta pee, and they are in there for 18 minutes. Doing substances, and we all know that, and that's why we keep Narcan in the bathroom, and that's why we keep Narcan in our scrub pants, and that's why we keep the CPR and the defibrillator right outside. We know that these spaces are at high risk of being used for drug use, so we keep them prepared for such. And we also all have like keys to get into stalls, so if people fall out inside of locked spaces, we have access. So we have these things put into place to make it safe. But I was a person that did just that, right? I walk into intake and I'm like, I'm gonna get lit in the bathroom before this lady takes me to my room, right? And I think I took like 11 or 12 benzos, so Xanax. I took a shot of dope, probably smoked something in the bathroom. I used a lot. My drug test came up positive for everything. But what else they do is they test people that are gestational age for pregnancy. It's just automatic. They don't tell you, it's just on the panel, right? And so I get my drug test results back, and they're like, everything's positive. And I said, yeah, I checked all the boxes. Like, I knew it was going to be. Like, I'm here for a reason. And they said, and you also tested positive for the HCG hormone, which means that you're pregnant. But because of your chaotic drug use, you are considered at high risk of having a miscarriage in the next week or so. So you're going to be heavily watched. And I was like in like a 24-hour Like I was in a room in the detox center where nurses had eyes on me all the time for the first couple days. I went through that whole treatment program under the impression that I would stay sober because of the fact that I was pregnant. And so I did not follow up with any of the suggestions that were given to me in terms of aftercare. Like I didn't get myself connected to outpatient therapy. I didn't get myself connected to MOUD or methadone. I didn't get myself connected. Thank you. To like regular therapy or anything like that, or AA meetings or anything. Because in my mind, and what I'm being told, right, what I'm being told by professionals and people is that if I love my baby enough, then like it's fine. If I just do the thing I'm supposed to do, just say no, right? Just don't do drugs, Bree. Like, don't you love your baby? Like, those were the things that were being said to me, and I internalized them, and I deeply believed that I would not use drugs simply because I loved my baby. And I say that, and I impress upon you the fact that there isn't a doubt in my mind that if someone gave me a lie detector test in that rehab and asked me if I wanted to stay sober so that I could raise this baby to the best of my ability, I would have said yes, and I would have passed because it was my truth. It was my truth. It was my truth. My circumstances did not allow it. Okay? So I give birth. I use the whole pregnancy. I get out of rehab. I do cocaine until the day I give birth. I give birth to this baby girl. It's not lost on me that I'm extremely lucky that she's healthy. She's perfect. Awesomest human that's ever existed in the world. That child was born on July 2nd of 2011. And they are my absolute best friend. I left the hospital with that baby, but under strict supervision of CPS, and then shortly after, CPS just took the baby because I wasn't doing what I was supposed to do. So my child went to not the best home, right? And that's often too, like what we face as birthing parents is that they don't give us like autonomy or choice as to where our kids are going. And oftentimes we might not find out for days or weeks where our kids are. And like, I can see that being beneficial, I guess, if like the parent was physically assaulting, like if there was like there was none of that existed for me. I had never been accused of a violent crime. There had never been any physical assault things in my history. I was not at risk of being a violent person. And it's interesting because all of these things are what do they call those, like ACEs, right? Like those screening devices, the experts, the audits, the ACEs, all of the things that we have to do. I always tested in the most severe, except violence. I'm simply not a violent person, and anytime I was screened for violence or anger or homicidal thoughts, I got a 0 because I just simply don't, that's just not in the thread of who I am as a human. I'm very soft and sensitive and like gentle, and that's just who I am, right? But I was viewed as somebody that was very dangerous and that needed to be kept away from their children. So my child goes to a home that ends up not being the greatest, but in child welfare, like law, it's better than a drug user. And fun fact, that person had lost custody of their kids and got mine. But you know, who am I? Who am I to have an opinion on who comes out of me? And so this experience starts happening right away, right? I lose my child. They go to a home that I don't feel comfortable with them being in, but I'm given no option. I'm given no autonomy. I'm given no choice. They're not calling me and asking me how I want my baby raised. They're not calling me and asking me what formulas I want to use. I get no say. No say. None. Okay, you think I knew when my baby was at daycare? No. It's very traumatizing. It's extremely traumatizing, and it doesn't go away when substances enter the body. I think it's one, and it's not just my opinion, it is like the mass opinion of people that have given birth while using drugs, that it's like one of those things where I don't know, and maybe there's a study on it, but I feel like if it was studied, it would definitely show that when you give birth, like the chance of ever getting sober after birth and the trauma of losing that child probably is reduced tenfold. There's no doubt in my mind that a statistic would show that if you continue to remove kids from parents that are using substances, that their recovery rates are just going to diminish. I went from having a truth in me that sobriety was something that I wanted to losing the most important person in my life to having no desire to get sober. Like, the outcome was directly caused by my baby being taken from me by strangers. And the person that took my baby was given the resources I needed to get better. Okay? So I did not get sober because what the fuck, why would I? you know? And so, and I had like the cutest baby too. Like whoever had my child for that period of time, they're back at home now, but whoever had the cutest fucking baby, and they didn't deserve it because they didn't make it. So, you know, I deserved that baby. I made that baby, you know, and birthed her in 36 hours of pain. Like I had this baby, and she was my soul and spirit. And so the devastation, right? And how much lower sobriety or change or recovery came on my priority list once she was taken from me. It just didn't mean as much to me anymore. A year later, my baby is a year old. I got pregnant again, and I gave birth October 24th of 2013. And I used that entire pregnancy, and I would say that year, a year and a half from when I had my first child to when when I gave birth in 2013, was absolutely the worst of my drug using years. It was 100%. I was living in and breathing and drinking and eating trauma. Like, I was just survival mode. I can tell you right now with certainty, and it's actually something that my best friend used to say that I really identified with, and so I stole it from her. But it's something a lot of us survival drug users that had kids say, is that I'm alive here today talking to you because heroin was available to me. Because there was a time in my life that I would have killed myself if it wasn't. There was a time in my life where I had nothing in my life offering me any feelings of relief except drugs. Okay, so there is a period, a year and a half period of using where I promise you I am alive today because I did not stop getting high. Because that was the only way I could live and face and understand and accept everything that was happening around me as a result of my drug use, including the separation of my child. So I was a survival drug user for this year and a half, staying alive simply to get high, and getting high to stay alive. Like, that is my life, right? I was really heavily traumatized at the time. I was taken against my will and kept in a basement for a few days. And that's like I conceived and found out I was pregnant a month after I escaped. I escaped the basement. I ran to a 24-hour gas station that was open at like 4 in the morning. I ran to it barefoot wearing this man's t-shirt. He drank enough to finally pass out on like day 3, and that's how I was able to get out. It still wasn't easy to get out because I was in the basement, and he had 3 very, very large pit bull dogs that I was afraid of. And I was also extremely intoxicated because he kept me like connected to heroin. So I left mostly unable to really walk. I was very inebriated at the time, but I knew it was my only window of opportunity to get out. I think if anyone here has experienced physical trauma, like a car accident or something, you don't know at the time how bad your injury is, right? Like, you see people get shot and walk to the hospital because like adrenaline is running them. Like the will to survive is like getting them to the door of the emergency room, and then they're falling out, and the doctors are like, bro, you're it's like in your lung. How did you do that? But like the human body's will to survive is so great, and people underestimate it. So I did not know at the time of me walking to the gas station that I was as injured as I was. But I got help, and I did this case did not go anywhere criminally, because I was immediately interrogated about why I was only wearing a t-shirt and the track lines on my arms, while they were sewing my anus back together. The priority conversation was, how did you meet him, and what were you doing, and whose t-shirt is this? Like, it had nothing to do with the experience that I just had. So I obviously just like got the health care that I needed to be able to function, and then like dipped and never went to the police about this man. This man is in prison now for doing this to multiple women. So like, none of us mattered because we were all drug users. I feel peace with the fact that he eventually did get caught doing this, and so he was actually released maybe 3 or 4 months ago. I got an email from the Department of Corrections about it, because I am written in case history. So that man reached out to me on Instagram. So like, it's like these things, right? Like that's one example of a very common trauma that happens for women that are using drugs that do not have the protection of housing or support, right? And that's why housing first initiatives are the ones that work. Protection and food and shelter will give you success. Anyways, I didn't have that. So I find out 30 days after this assault on me that I'm pregnant, and I found out because I was getting high, like I do, and I was getting really sick when I was getting high, which was not the normal for me. So I was worried. This is before the fentanyl and xylazine stuff, you know, like I was using heroin, right? Like with some maybe laxatives cut into it. Like I was using heroin. So it was weird for me to have these symptoms that I was experiencing when I would use, like a heavy vomiting, nausea. Even like the nod wasn't as satisfying as it was prior to. So I thought, you guys, this is like the delusion of a drug user sometimes. I can make fun of myself as a drug user. I went to the hospital and I was like, I think the dope man's poisoning me. And the nurse was like, you are poisoning you because you used the drugs. And I was like, heard. Anyways, I'm here because it's making me sick, you know? And I'm like this guy on State Fair is like plotting to take me out. Like, no, okay, this man was not poisoning me. Like, I went there with $20, bought 2 packs, that shit made me sick. And what they find out is that I was getting sick because it was just morning sickness that was getting exacerbated by like the scents and smells and the physical experience that drug use has, right? So I'm like, because the first time I had thrown up was when someone had smoked drugs right next to me, and I smelt the smoke, and I vomited right there in the middle of the shooting gallery, which no one likes. And you know, so like they tell me I'm pregnant again, and I'm like, this is such a buzzkill. This is awful. Like I can't. Like I already had a baby, lost that baby. That baby at the time, like, had a relationship with me because I was doing my visits, right? But it was not a relationship that looked like the typical 1-year-old and their mom or infant. Even at times, you know, my baby, I was visiting my baby from when they were a tiny baby. So although it didn't look like the typical mother-child relationship, they knew me and they loved me and we had a great experience, but I could not do it again, right? I'm like, I need to have an abortion. Like, I can't. The trauma of giving birth on drugs, having everyone treat you like shit, and then like a stranger taking your baby to another stranger's house who you later found out couldn't even keep her own babies, but was getting checks to raise yours. Like, I'm not signing up for this one. Like, you guys tricked me last time, but I'm not signing up. You know, we're just like abort mission. So I make an appointment with, an OBGYN provider with the intentions of terminating this pregnancy. And before I can get to this appointment, the hospital that I went to calls me back and says, hey, I know that we told you were pregnant, but we ran your blood through the lab to see how far along you were with your HCG hormone. And I'm calling because you were just here and you're very small. Like, I was a drug user. I was a very small person at the time, but I had a extremely high HCG hormone. So she was concerned that that could be a result of me miscarrying or something because I'm so little. Like, and your HCG hormone gets higher as your pregnancy goes on, or it jumps up real quick before a miscarriage, right? Like, that HCG hormone flushes out of your body when you have a miscarriage. So she's like, I'm just kind of worried, wanting to make sure it's not super high for something bad, because like, you don't even look pregnant yet and your HCG hormone was like measuring that of someone like full term. Okay, so they're like, can you come back? So I go back to the hospital, and what I end up finding out was my HCG hormone was so high because there's 3 babies, and I was pregnant with triplets, and so your HCG hormone is also multiplied by how many fetuses are inside of you. So I did not go through with an abortion at that time because it then became like a complex issue as to, because I can only talk on like my experience. Like, since I was very little, I wanted a lot of babies. I'm one of 6 kids, and I watched my single mom and the 5 different dads that brought us into this world but didn't stay. Like, I watched my mom do these things, and even though we struggled and these men weren't always great and food was not always available, I loved having so many siblings. And from a very young age, everyone knew this about me. It was like what I did, as a first grader, what do you want to be when you grow up? It is what I did reports for in middle school and high school. It is like what I talked about. I wanted to have a bunch of fucking kids. And I had triplets when I was 23 years old, and I had a 1-year-old when I got pregnant. So I had a bunch of fucking kids. And And so like this complex confusion for me with the abortion came up because it's not a moral issue. I am very pro-choice and was very confident that an abortion was the best thing for me. But then I'm still like this human that had this little desire, my little girl inside of me, like the little child that grew up and had these desires and wants for their life still existed. And when I found out it was triplets, so I grew up wanting all of the babies, and now I have, like, the babies, they're mine, and there's no reason genetically or medically that I was able to get pregnant with triplets. I was not on, people ask me all the time or just outright assume that it was IVF. Bro, I lived on State Fair outside smoking crack. I was not on IVF. No. Maybe that crack was cut with fucking prenatals. I don't know. This was spontaneous, completely random, and in the wake of the worst trauma of my life, and my older baby was not with me. So I used that pregnancy as well, but I did go into a rehab, an inpatient center that I would later work at, but it specializes in detoxing and inpatient treatment for pregnant women. It's called Clearview. I'm sure maybe some of you have had clients go through there, or you've had to take care of people that utilize that program. So I went to Clearview and I did stay for a couple months, but there was still a few months in that pregnancy that I was using, and I ended up giving birth over 3 months early to three 2-pound babies, and I started using right away. And I'm throughout the time of me getting hospital care and me being at the inpatient treatment center I was going and see, I did have the experience. It's also not lost on me that I'm very lucky that I don't know what it was that drove me to do it, but even throughout that experience, I was going to my weekly prenatal appointment. I was showing up. I had Johns, because I was a sex worker. I had Johns taking me, rehab taking me. I didn't care. I got to every Friday appointment. Those were 3-hour ultrasounds, so I always had to go prepared to know that I would go into detox before it ends. So, you're thinking of all the pieces that I had to get into place every single fucking day for me and those babies to survive was wild, and nobody was helping me. Nobody. So all of these times, all these places that I'm going to, and never did anyone have a conversation with me about alternative solutions to what I was dealing with. Never did anyone bring to me a plan of action as to how me and my children can be successful. Never did anyone come up to me and tell me about different MOUD options or interventions for drug use. Never did anyone come up to me and talk about these things. Never. I was talked to about what crimes I was going to be convicted of, where my kids were going to go, and they told me the plan was to split the triplets up because it would be too hard on any single person to have 3 medically needed infants, right? Because the triplets were born 3 months early, and one of them had heart surgery right away. So they were like, we can't put them all together because it would be too hard on one person. Even saying it out loud, it sounds so wild to me that these people would bring me solutions like, let's split your triplets up into 3 different homes that you don't get to pick, instead of using the same money to get me a home and some cribs and some medication. Even saying it out loud right now makes me so fucking mad. I want to go and I want to hit all of them. It never dawned on you that this 23-year-old person that was pregnant for the second time with her second, third, and fourth children deserved some grace? It never dawned on you? It makes me mad for 22-year-old Bree that almost died because of it. It makes me mad for that version of myself that asked and wanted and desired something different and better and was just never given a space to get it, right? So my babies were born, and this time, all 4 of my kids went to go with my mom. My mom and me have a very complicated relationship, as I kind of shared. She also comes from trauma. There's some generational stuff going on. Teen moms from my great-great-great-great-grandma, having kids by 15. So my mom we have a complicated relationship. She is a person that has caused me a lot of harm. She was abusive when we were all very young. So it was hard for me to come to this decision to have them placed with her, but it was my only option I'm telling you, okay? I was given one option, and it was my mom. The state gave me one option of where my babies could go where I could visit. So the only option for me to be able to see the triplets that I had just birthed, that are infants, newborns, is to put them in a home that I was previously unsafe in. And like that feels really shitty to me too, to even say 13, my triplets are 10 next month, 10 years later, like that still feels shitty for me to say that I had to make a choice to put my kids in something that previously hurt me just so I can see them. Like how do you make that decision as a mom? Like I know this woman hits kids because she's hit me. So I'm gonna put my kids there? But then if I don't, and I put it with this woman who I know doesn't hit kids, I don't get to see them. You know, selfish Bree wanted to see her kids. Nothing ever happened in that home. It was very much my sister and my grandma stepped up and did a lot of work with my children at that time. October 24th, 2013, I gave birth. December 25th, 2013, 2 months later on Christmas Day, I went to prison. And I did not see, speak to, or have contact with, in any capacity, my 4 kids at that time. Because I was not allowed to, because of my so what I went to prison for was for being a substance using parent, and 4 counts of endangerment to a child, 4 counts of improper supervision of someone under the age of 18, and 4 counts of substance using while parenting. Like that is what I was convicted of. That is what I went to Huron Valley for. That is why I'm on the National Registry of Child Abuse and Neglect, okay? I have never hit a child in my life. I have never neglected a child's needs in my life. I have raised several children, including ones that aren't mine, and I'm on a registry that says that I abuse and neglect children, and I will never get off that registry. I tried, and they said, fuck you. And so that is, like, those are kind of like the parts of the story that I want to focus on, that like really encourage you guys to consider the ways that language and policies within your workplaces and within your practices have caused outcomes like that. Because there are so many people at fault. Like, but what everyone wants me to believe is that it was only me that was at fault because I was the person putting drugs in my body. Like, that is what we all want to believe. That is what we are told from when we are given the first dare talks at school, right? Until forever. Like, society's overarching belief is that the fault of those situations is on the person using drugs and nobody else. And I am here to tell you that I take full accountability for my part and that I am aware that I made really bad choices as a parent, but there are a lot of adults that were twice, 3 times, 4 times older than me, that knew better than me, that had been in this field for as long as I've been alive, that didn't do fucking shit to change it for me. And were fine and happy with putting my kids in a car and taking them off to the ether. They were totally fine with it. So there is a lot of fault in healthcare, criminal justice system, and the welfare system that put me in the position that I was in. That was not because I was a substance user. Heroin does not cause any of the things that I had now dealt with in the story that I just told you, okay? By the time I gave birth to those triplets, most of the problems in my life were not heroin related. All right, it was trauma related, and it was not having access to resources, and it was doctors thinking that they know better for my children than me. That is what caused it, right? I did not harm my children. I did not abuse them. I did not neglect them, but a bunch of fucking social workers did. And that's my truth, and that's real, and that happens every day. So some of the things that I want to like bring what Erin has taught you guys so far into like my story and how it directly impacted me, like those stigmatizing language, right? Stigmatizing language, referring to me as a junkie, as a crackhead. That was something that I experienced. I will say I see progress in that space because when I was a drug user 10 to 15 years ago, those words were still like very prevalent, and it was something that I heard often. But now in the field, working in an inpatient center, previously being really immersed in the drug using community, that word has kind of started fading out, thank God, because we are making a lot of corrections around that. But at the time, I dealt with a lot of stigmatizing language around the word junkie. Crack babies was probably texted to me at least 20 times. You know, like, who refers to newborn triplets as crack? I can't. literally I can't. And so all of the stigmatizing language that I had to face that had all of the outcomes that you see on these slides that have been proven through studies to be outcomes in healthcare situations due to stigma, lack of resources, drug use, whatever situation we're looking at, happened. All of those things. I'm like, when I was standing over there behind you, I literally did that. Like, I am one of the numbers in a lot of those graphs. Most of those graphs, I am one of the 100 of 30,000 people. Like, I am in all of them. Like, those numbers people forget so often. I have to remind social workers all the time, especially ones that are in the field but not with lived experience, right? They are social workers because they want to make change, not because they've been traumatized. That, like, these are not, Aaron did not draw those graphs this morning. Okay? Those are fucking people. Like, so many people that I loved died in the last 2 weeks of overdoses. I don't know what happened, but a bunch of people that I know died. And like, all of those people are going to be on next year's graph. And like, you should be bowing your head when you see that graph, because those are people that were loved, that were created in whatever God's image you believe in, that were needed and wanted and desired by the people that loved them. And there are people in every drug user's life that do not fucking care that they're a drug user. And I have personally 4 people in my life, well, there are more, but the most important, there are 4 people in this world that could care less if I did drugs or ever do drugs again. Because in my children's eyes, I walk on whole ass water. Like, I am still mom. So how all of us, I know some of us have shitty moms like me, but for the most part, a lot of us understand the concept and have empathy around the fact that, like, mom is mom. There is not shit mom can do where she ain't mom. Even my crazy ass mom, that is still mom. I will still take you out for my mama. That is mom. For my children, that is their truth. I am mom. They never wanted to be taken from me. They do not believe, my 12-and-a-half-year-old who's in 7th grade does not believe that she ever had to be without me for me to get better. And she knows everything about what's happened. She was raised in the rooms of Alcoholics Anonymous. She has been to probably 5 or 6 of these trainings that I've co-facilitated in the crowd. She knows how to use Narcan. She has co-facilitated Narcan trainings with me, okay? She carries Narcan in her bag. She has been on my syringe service van. She has gone out with me on Halloween and Christmas to disseminate candy and fun things for the drug users that I see. They know a bunch of drug users that get regular supplies from me, and when we see them walking around, because we live on the east side of Detroit, so sometimes we'll see some of the folks that use substances that come and get clean supplies from me, and Meadow, without hesitation, runs up, Jesse, oh my God, hi, Mom, look, it's Jesse over here. And it's someone that they only know as a drug user that gets syringes to me. And it does not change my child's perception of that person. And it's because of how I raised them, but also because their perception of me has never been different than mom. Like, I just was always mom. Everyone else cared about the relationship I had with drugs, but not them. And so I think it's imperative to remember that there's people in the lives of drug users that are not looking at them through the same lens as social workers, cops, judges, and doctors. Like, the lens in which my children see me isn't even affected by my drug use. Like, they're obsessed, annoyingly obsessed with me. And I laugh about it because, like, if you looked at my social media, you'd be like, that poor person probably never gets to breathe or shit by herself. And that is accurate because they're obsessed with me, okay? And they sleep with me, my 12-year-old, every day. Like, it's real. Like, it is a real close bond. I got custody of my kids back on July 17th of 2015 after, I did the math once before. So it was like 547 days of my children being separated from me from birth until I got them back. And I went to court that morning, a 24-year-old with a year and a half sober. I would have turned 25 in August. So in July, I was 24, maybe a year and a half sober or something around there. And I drove home with 4 kids. Like, my life changed drastically that day. Like, I had been living in a shelter in a transitional home prior to that, and got a job. And because of my tether, my criminal background, my tattoos and the way people view drug users, I was put in like the back of a house at a restaurant, you know? Like I applied to so many places and nobody wanted me in their business. Like, and finally Red Robin was like, you can make salsa. Like, that's fine. Like, you can do that. And so I did that, and I got an apartment eventually, and I went home one day with 4 kids. And that was wild, right? And I and like that example too is so it speaks so loudly to why resources cannot be short term. I remember when I was 2 years sober, my therapist called me and said, "Hey, we got to do some paperwork because insurance cut you off for therapy because the Medicaid guidelines at the time were that at 24 months of sobriety, Medicaid would no longer pay for substance use as a primary diagnosis because they believed at that time if I've been paying for you to get substance use treatment for 2 years, you should be fine." And like my therapist is like, "The bitch is not fine." Like calling Medicaid, like, "Nope, not fine yet, not fine. Bree is not ready to be released. Like, we need more." And so they actually had to change my diagnosis to be primary general mental health. And the only reason that worked for me was because I was hospitalized several times as a young person from the ages of 14 to 20 in psych wards for suicide attempts. So I had access to diagnoses that were considered more severe than my substance use disorder. So they were able to make me a general mental health person on Medicaid versus a substance use disorder person on Medicaid. And I still see Nancy every single Thursday 10 years later because she did that. So those are the different, there's another thing I hadn't even thought of that since I've met Erin. Like, and there's another example of like a random barrier and red tape. Like, who in their office one day at the Medicaid office was like, "How long do you think they need therapy? 2 years? Yeah, 2 years? No, I have been smoking crack for 7. Minimum 7 years." Like, that's real. Like, who thought of that? Who thought of that unnecessary or barrier to care? And so many of the barriers to care are so unnecessary and do not. And I loved one of the statistics that was on here about when like the cities that have higher like criminalization of drugs are also the ones having more births on drugs, right? So like if we can prove that this barrier is not actually decreasing harm, then what is the purpose of the barrier? Who benefited anywhere from being kicked out of therapy after 2 years? When did that barrier get created? Why? And what did they think the outcome was going to be? Higher suicide? What do you think happens when people get abruptly taken out of therapy? So take all of that, right, and come back to my life in 2015 when I drive home with 4 children. And the last 10 years of my life being so radically dictated by the drugs that I used when I was a teenager or an early 20-year-old, it is insane how often the fact that I was a drug user, despite my decade of sobriety, despite the thousands of drug tests I have passed, despite successfully reunifying with 4 children under the age of 2, after previously signing an agreement to let somebody adopt my kids when I was on my way to prison, I fought the state at the highest level of court in Lansing to bring my kids home. It was not family court. They were sick of me there, and I just don't shut up. So I ended up in Lansing, and I brought my fucking kids home because I don't know who they thought they were talking to. I did not go through a triplet pregnancy for anyone else. And and so even despite the fact that I have succeeded and actually pissed off the state on several occasions because they didn't want me to have my kids back, that even with that truth, right, it's truth that I can prove. I have all my drug test results, right? My kids are at home. My bank account's in the negative because I feed them. I can prove all of the things that I have to offer my children. Like, I'm working, I'm picking them up from school, they're signed up for all the things. My oldest child is in travel soccer, which costs way too much money, and my youngest 3 are in swim, okay? So, like, my kids are living their best life. Literally the day that Lansing called me to tell me that my expungement was denied, me and my children were on my boat. And I literally laughed so hard. I'm on the phone. I can't get off the abuse registry. When these motherfuckers are on my boat, come get these kids then. Okay? Your Honor, come get these kids. I'm trying to chill on my boat alone then. Because if I'm going to be on a registry that says that I should not even be around anyone under the age of 18, then somebody better come feed these kids, babysit for me, or do something. Because y'all brought them to me in a van with a little sticker on the side that said Michigan Department of Health and Human Services and dropped them off at my door and never came back to see if I was doing okay. So if you don't want to expunge this shit 10 years later, then you better come and get these fucking kids back because they've cost me a lot of money. Like, if you want me to do all of the work and then just only ever suffer punishment. Like, what, when and where, like, something that was said too is like, where else in medical do we do this? When and where in other situations or circumstances is our response to like continuously traumatize a person and to hold it over their head for the rest of their life? 10 years later, and I'm still having to have conversations. One of the other stigmatizing policies that really affected me was one of the earlier ones that we talked about, which was like the registry and the hospital's policies that they can kind of just cherry pick. And also, it comes down to like individual service providers. I could have a morning shift nurse give no shits about what I'm doing, and then a mid-shift crotchety Karen nurse come in and start making phone calls, right? Like, it's so individualized. It's based so deeply on interpersonal bias and stigma and discrimination that it almost doesn't even matter if a thing is a law or not. Because, like, if it is or not, and you still get to decide whether or not you want to hurt me, then, like, okay, they're going to pick to hurt me. You know, if they don't like drug users, then they're going to hurt drug users. It doesn't matter if something says that you're not supposed to. It certainly doesn't matter that it says that equal housing, equal employment, equal medical. It doesn't matter that those signs are in your lobby if the nurse that you hired is racist, right? Like, it doesn't matter that it says that that's not allowed if you hire people that don't like folks. So one of those things was the registry. And so I switched my oldest child, right, moved up to middle school, and the triplets are in 4th grade. And I am not allowed to go on any field trips. I'm not allowed to volunteer at their school. I'm actually not technically allowed on their property, and they had to approve me being able to go to the drop-off line to say goodbye to my kids. Okay, because I am a psycho child abuser. How many more minutes? I can end now. Yeah, I can end now. So that was just kind of like the final example of like a policy and stigmatizing like language and barriers that really don't provide any positive outcomes, that still, despite drug use being removed, despite family reunification occurring, despite parole disclosing my case, I'm still having to like trudge this road of proving to people that I am safe enough to take my kids to school. You know, like I had to have a meeting with the superintendent of the district. Like, that is literally what happened. So I encourage all of you guys to consider what policies and language within policy and hiring practices that are happening at your organizations that are making it so folks that are trying to do the work to create change after substance use, after trauma, after incarceration, that we present those opportunities. I work at a syringe service. It took 2.5 months for me to start because of my background check. And I work for an organization that hands out crack pipes. Like, that is still, and it's nothing that the organization I work for wants, but it's literally because the grants that pay me are requiring these things. It's because LARA and the different accreditation agencies are telling them that they can't hire felons. And I really encourage you guys to look at those practices and which ones you have control over and which practices you practice individually, and check in with your bias and see what policies are in place or not in place that I am still causing harm in when I don't have to, because it's an internal bias that I'm fighting. So I'll end with that. I appreciate you guys giving me space. Does anyone have questions that they would like to ask about my experience with hospital staff and giving birth on substances? Yes. Yeah, so there's so it's an organization. So Sacred Heart is the main medical provider. So Sacred Heart is in Richmond, Michigan, okay, which is Macomb County. It's it's a good rehab. Like we have some good rehabs in Michigan. I would say Sacred Heart is one that is state funded, so Medicaid users can use it, and so it's accessible, and it has a lot of beds, right? So it has a lot of it checks off a lot of good boxes because of the accessibility. Next door to that rehab, but owned by the same healthcare organization, is Clearview, which is the inpatient center for folks that are pregnant or have children. Yeah, it's on there? Oh, nice. Or have children that can live with them on campus. So yeah. Oh, perfect. So Clearview got added to that. So that is a great, and you know what else is really great about that program is even though I hate CPS, it's what we have to work with. Clearview is an approved CPS supervised site. So even if you had, like my child lived with me there, even though I did not have custody with Meadow at the time, I was able to take her and spend 30 days with her at rehab, pregnant, because that was a supervised CPS place. I was never alone with my baby. There was nurses there, social workers, peer recovery coaches. Like it was a space where they knew I could be safe. So that was a beautiful experience I got to have while pregnant with the triplets, is to like hold my baby for 30 days without interruption before I had 3 more babies to hold. So things like that, like that's a perfect example of like, what can we do here to make this a little easier? Like, and less shitty. Can we make this space safe for kids so that the moms can hug their children when they're hurting? Like that seems like an easy fix. I'll ask again if anyone has questions. I do have one positive example of what changes when someone uses inclusive language that I would like you guys to hear, so that you understand the impact that it could have on the clients that you work with. Does anyone else have a question for me? No. I'm sorry? Yeah, so now I work for Access, which is the Arab American Center for Education and Social Services, and they have a really great syringe service program in Sterling Heights. It's been very interesting because I do all of their syringe stuff in Detroit, but the main office is in Macomb County. So what's very interesting is that I'm very much working with a different demographic of people that I'm used to. I'm working in a predominantly Arab organization, an Arab run. It's the oldest Arab American nonprofit in the United States, and it does amazing work for the community, and anyone can access services there. And it's a really beautiful environment to work in, but it's been really interesting to learn the cultural differences of substance use and parenting between Arab Americans and the folks that I've previously worked with, which was Black folks and folks living in Detroit, right? Like, so it was very different. It's a learning experience, but I love Access, and I encourage you guys to look at what services we have, because we're across all 3 counties, and we have several locations, and literally everything from GED classes to regular primary care to HIV prevention is all something that one of our locations has. They have WIC offices. Is it also on there? Boom, the first one. Yeah, they do a lot of things. So I encourage you. That's the organization I work for my 9 to 5. And I do like harm reduction trainings and things like this, and Narcan trainings and I'm a sex educator, so I do a lot of sex education on like contractual issues. But it's a great organization. So the story were you going to ask me something? Are you talking about after I left the hospital from having the triplets? Or like when I got out of rehab? Okay, so None. I did. So they do offer a space where you can meet with somebody in the rehab to get connected to outpatient near your home or something like that. It's not just like a given part of the program. You can be like, hey, I'm thinking about doing IOP, and they'll like help you do it. But it's not like before you leave, let's get you on Vivitrol, let's get you to a Suboxone doctor, let's get you some Narcan just in case something happens. Let's like, what preventative measures can we send someone to your house in a week to check on you? Like, what things can we do? And that's what I mean by I encourage you guys to see what practices can easily be changed. It's so easy just to skip over to someone's house to see if they're okay, you know? No, go ahead. If that's all the questions, then I'm good to. The story I wanted to tell you, because it's something that I still cry about when I think about today. So my triplets' names are Summer, Autumn, and Winter. I've told you this story. I was mistreated at every level of care throughout my life, and the triplets were not exempt to that, right? Like, even though my OB offered space for me to continue to do what I was doing, trust me, a lot of people involved in the care of my triplet mom were not on board with letting me just do what I was going to do, right? Dozens of people were involved in the pregnancy, and 21 people were in the room when they were born because of the complications that I was facing. So that is big, and I was discriminated against. I would be talked to like I was so stupid. Like there's just no way that I know right from left. You know, just the way they spoke to me, the words that they used, the way that they wrote things in my medical chart. Like, I'll read through some of those notes that are in my like Beaumont app, literally notes in my Beaumont app that like are not clinical words. Like, that was your opinion of me, not what I went to the hospital for. But I had this nurse that would come visit me every time I went to the doctor's. She was at every single ultrasound. She held my hand through many bad news. Her name was Autumn. And she would bring me journals, and she would bring me self-help books, and she would maybe ask to pray with me. And then one time, unannounced, I was in rehab at Clearview, pregnant with triplets. I go to group, and Nurse Autumn is there. And she embraces me and was like, I wanted you to have support beyond when you're at the office, like when you're in the hospital room, right? I believe, like, she looked at me and she told me, and I've told you this, and I cry every time, she looked me dead in the eyes and said, I believe that you can do this. Like, if no one does, Bree, I believe that these children are best suited with you, and that there's a reason why you're having them. And I want you to raise these babies, and I will help you. And I named a child after her. Like that, because it was so impactful for me. And it doesn't mean I got sober after that, right? I still used. It was so impactful to my spirit as a human with human needs to have someone look at me and say that they believed in me, and that they believed that those children wanted a mother like me. And like, how huge is that? That this nurse did that, and that it couldn't escape me. So when I gave birth, I have a child named Autumn now, and it is after Nurse Autumn, who loved me regardless of the fact that I had a relationship with drugs and alcohol when I gave birth. That is the impact that you guys and people on the ground can have when they talk to folks that are pregnant in a way that humanizes them.
Yeah, that's a really good example of like the impact of language and using a non-judgmental approach. So we're going to talk a little bit about it. If you need to step away, because I know we didn't have time for a break, that's fine, but I want to make sure we get the important information in. So we don't know a ton about exactly how to reduce stigma towards patients who use drugs and people who use drugs, but we have some research in this area, and this is what my expertise is in. So I'll tell you a little bit about some ways that you can reduce stigma and that I'm working on with like my colleagues at Wayne State and our healthcare programs at Wayne Health. So one of these is adopting that trauma-informed approach to your work we've already been over, and I'm sure you guys are actually very familiar with, perhaps more familiar with than I am. But you can also use some things that are sort of my areas of expertise that we use in medicine that have been shown to have some promise. So adopting what's called principles of patient-centered care, and then implementing motivational interviewing skills, again, something you guys probably know about, but these are especially effective with patients who use drugs. And then also integrating harm reduction approaches into your work, which we're going to spend more time on today, because that's probably what you're less familiar with. So when I talk about patient-centered care, this is a concept for medicine, but really could be applied to any type of services. This is basically an approach to healthcare or services that really centers the patient's needs in a non-judgmental way and sort of tries to move away from that expert, authoritative role that a lot of times doctors or service providers have. So in patient-centered care, we're prioritizing care that aligns with patients' unique needs, preferences, and values, instead of prioritizing compliance, right? We actually don't even use that word compliance anymore in medicine. We say adherence, which is slightly less bad, but really our goals should be to help them identify their needs and try to help them get there to meet them. Our power relationship is more equal in this approach as opposed to the clinician, nurse, provider, whatever, having a bunch of power over a patient. We try to do shared decision making. We try to say what's going to work for you, how can we get you towards this goal that you have, as opposed to the provider saying this is what's best for you, this is what you should do. We hear that a lot in addiction medicine, right? That you should just stop using drugs. This is what I want you to do. I know this is the best outcome. But that's not necessarily shared decision making. That's not necessarily what the client or the patient wants. Also building mutual trust as opposed to having sort of distrust of the patient. So the providers often distrust patients too, right? It's not just the patient distrusting a provider. And then also having this idea of cultural safety. So paying attention to those intersectional stigmas of racism, sexism, homophobia, classism, and ableism, as opposed to ignoring them, pretending well, I'm not racist, I don't have to worry about this. Or I'm a good doctor, I treat everyone fine, right? So really being reflective of yourself as a service provider, as a clinician. And so one of the ways to achieve patient-centered care is to use motivational interviewing. And I'm sure you guys know about this, probably know about it more than I do, because I don't actually do it in my work. But it's a communication approach to help patients to identify their own goals and take realistic steps towards them. So we use MI in this patient-centered care approach, and especially with individuals who are averse to change, who are not interested in stopping drugs. Maybe are not even that open to using drugs less or maybe more safely, just really are not interested in changing what they're doing. How do we help this patient? How do we help that client? There are ways that are successful, and motivational interviewing has been shown to work with the most averse to change clients, okay? So, of course, the spirit of this is compassion, acceptance, and collaboration. So that means being non-judgmental, respecting patient autonomy. They have the right to make choices, even if we don't agree with those choices, and then working with patients to set their goals instead of telling them this is what we think you should do, right? And then those basic MI skills that you already probably know are doing things like asking open-ended questions. What would you like to change about your health? Affirming what they're doing. So acceptance is building trust, saying things like, I understand how that's stressful. Reflective listening, so saying back to them what they say to show that you're listening to them, and then highlighting times they do talk about change in these summaries. If there's a lot of engagement resistance, that's okay. Try it again the next time you encounter them. Don't give up. So we will skip the videos, but when thinking about ways that maybe agencies or organizations can reduce change, one of those main ways that we know can work is education and training, what you guys are already doing right now. We know education, at least in the short term, makes people less stigmatizing towards patients and clients who use drugs and more accepting of the evidence-based practices. We don't have great long-term studies. That's something we're all working on right now, is say, in a year, will this have affected the way you do your work? We don't know that, but we know it works in the short term. But also some of the research has shown that collaborating with harm reduction programs, like those programs that are listed on the back of your one-pager, which include Access, Clearview, CHAG, what else is there? Harmless. So these are syringe programs, medication treatment programs. Collaborating with them can also transform your organization because it changes some of the interventions that you're able to offer, but it also can change sort of your perception of those interventions and those clients because you're going to see success when you refer people to these evidence-based service providers and not just the service providers who maybe are not using evidence-based practices. There are plenty of treatment providers in every state and every locality in this country that offer addiction treatment services that are not based in scientific evidence. And so they're not going to work very well. So you might not think that these people are helpable if that's who you're referring people to. So it's important to refer people to the spaces that are using evidence-based practices. And also, of course, there's policy changes that could be implemented at the state level, but also at agency levels as well. So education and training, one of the things I've already done with you guys is the most successful method for changing stigma is what's called contact-based intervention. That's part of why Bree is here. Bree is also an expert. She's not just someone that has firsthand experience with substance use disorder. She also does this work on the ground helping patients who use drugs. But we know that this is one of the most effective ways for changing people's attitudes towards individuals who use drugs is showing people's stories and what worked for them, what didn't, humanizing them. So we're actually already doing that in this training. Also having critical reflection opportunities. So at the end, I'm going to ask you guys to think about what could you change about your practices and your work based on what we presented today. So that's what we mean by that, is sort of thinking about how you do use this information in what you're doing. Also improving provider skills for patient communication, so doing things like making sure you're using motivational interviewing and patient-centered concepts when you're dealing with clients. Increasing the knowledge of the science behind evidence-based practices, that's what we're doing next. I'm going to talk to you about the evidence behind harm reduction and medication treatment. And then there's some evidence that may be showing that substance use interventions are needed in our community, that we have high overdose rates, for example, could be helpful for convincing people that, we need to address this stigma. In terms of interprofessional collaborations, that could be like formal partnerships with places like Access or like syringe programs. And in terms of government or organizational policies, it could be things like explicitly having MD, HHS, and other sort of leadership in the organization be very explicit about their support for harm reduction and treatment and destigmatizing substance use. And then possibly there's some evidence that maybe eliminating policies that exclude patients treated with MAT to like services. So for example, patients treated with methadone are sometimes denied inpatient rehab beds, making sure that those policies are in place and we get rid of any sort of funding for organizations that do promote sort of like exclusion of those patients. I'm going to skip this one, and I'm going to move on to harm reduction because I need to make sure we have time to cover the evidence-based interventions that we're saying work, right? So what is harm reduction? So harm reduction is another evidence-based practice that we can use to reduce stigma towards people who use drugs. I've already gone over what it is, right? It's that approach to addressing people who use drugs that try to reduce the negative consequences of that use and not just focusing on abstinence or stopping the use altogether. That can be a goal, but it's not the only goal, and it's maybe not even the main goal of what we're doing. So harm reduction strategies do what we say, meet people where they're at. So by that we mean if people are ready to stop using drugs, we help them do that. If they're not ready to stop using drugs, they're not willing, they're not able, we also help them to reduce the negative effects of that drug use. So sometimes people who don't like harm reduction say that we only promote drug use and we're not interested in helping people stop their use, but that's not true. If someone wants that, every harm reduction program will help them with that goal. And when we're talking about safer use of drugs, that means even with patients who are pregnant. I mentioned before that detox is not where we send pregnant patients who use opioids. I should say that. If they're using different drugs, detox might be an okay intervention. But for opioids, the goal is really safer use of drugs or transition to medication treatment. So I'll say more about those. Do you want to go ahead?
I just wanted to. Oh, wow. So statistically speaking, if you have a relationship with a syringe service program and you are a person that uses substances, you are 5 times more likely to be connected to long-term sustainable treatment than folks that do not have a relationship with a harm reduction organization. And that is because throughout their time of getting services, they're being met with where they're at, judgment-free, bias-free, barrier-free care. So when that time came where they had like the psychological, mental, emotional, or spiritual desire to change the trajectory of their life, they knew exactly where to go. They went to the providers that haven't been judging them, that haven't been calling them junkies, that haven't been treating them differently, and have been loving them despite their drug use for the last X amount of months or years. So now that I want to change, I'm going to call Bree, because Bree's always been great. And so that's like another way in which stigma and language will impact positive outcomes, is kind of creating a space where people know where to go when they are ready for help because of the care that they've been given before.
Yeah. And so harm reduction is often thought of as like a set of services, but it is also a set of values. But the services that are often included in harm reduction are things like syringe service programs, or SSPs. That's what SSP means. So syringe access, disposal, teaching people about safer use of drugs, giving them naloxone or Narcan, medication treatment, housing first, referrals, etc. These are all the harm reduction services. What's not included in harm reduction are punitive policies. So by that we mean punishment by policy towards people who use drugs for their drug use. So that means things like terminating people from care or services. We see that in healthcare a lot, people being kicked out of treatment or primary cares because they're not stopping their drug use. Jail or prison, loss of child custody, loss of government benefits like Medicaid or food stamps. These are all punitive, and they just aren't evidence-based for helping people improve their health and improve their drug use outcomes. Also, this belief that people who use drugs have to hit rock bottom before they can be helped is not harm reduction. It's also not based on any evidence. People do not have to get to the lowest point possible of their drug use in order to benefit from treatment or services. It's a myth. It's false. Anytime you hear it, you should correct it. It is not based in any science at all. As people in harm reduction say, rock bottom for some people is death, and you cannot help dead people. So we help people immediately as soon as we encounter them. If they're averse to change, we use those motivational interviewing skills. Everyone can be helped. I truly believe that.
I've actually had two primary care providers. This is way too, I don't know how to.
Okay. I think you still need to use it though.
I've had two primary care providers. Both of them were family practitioners. One of them I had been seeing since I was a pediatric patient of his, discontinue services and ban me from the practice for being a drug user. And the second one that did this to me did it when it was in between my pregnancies, and he was a family practitioner. I went there, I remember specifically going there for flu shot, and them asking for a urine, and thinking that they were gonna make sure I'm not pregnant before the flu shot, and actually they ran it for a drug test without telling me, and it came up positive for cocaine, and they never allowed me back in that office again.
Yeah, so this is not an evidence-based practice. Banning people from services for using drugs doesn't actually help them. Also, we know that doing things like policing strategies can actually lead to worse outcomes. So there was a very recent study by some Wayne State researchers, including some that I've worked with in the past, that showed that in places in Indiana, they just had Indiana data, but they're going to do it for Detroit too. After a drug bust, in that particular region, we actually see an increase in fatal overdoses after that drug bust. You might think, oh, but they took the drugs off the street. Wouldn't that mean less overdoses? Absolutely not. You destabilize drug markets. Now someone is going to a new dealer with a different type of drug that has a different sort of potency to it, and they have no idea what they're taking. So now the dose that they used to take leads them to an overdose in this new situation. So actually policing strategies can increase fatal overdoses when they take people's normal supply away. So we've actually known this for years by talking to people in the field, but now we have actual scientific data that shows statistically this happens. So what are those principles of harm reduction that we could use instead of these punitive approaches? So there's a set of values that guide harm reduction, and these are things like accepting that drug use is a part of our world and trying to minimize the harmful effects. We try to acknowledge that some ways of using drugs are safer than others, so that focus again on not just stopping drug use, but maybe making sure people are using it in the safest, least risky way possible. We try to focus on quality of life and well-being, not necessarily stopping drug use as a sort of goal for our interventions. We also try to be non-judgmental and non-coercive in our services. We try to ensure people who use drugs have a voice in our services and that they give us feedback and have power in our policies and programming. And then we also affirm the autonomy of people who use drugs, because ultimately they decide whether they use or not use drugs, and empower them to sort of share information with each other. Actually, we're the main sort of source of health information for a lot of people who use drugs is other people who use drugs. So if we can help that one person, that information spreads, and they can help their friends and peers to be safer as well. We also recognize that intersectional stigma piece, that poverty, racism, trauma, and other inequities affect people's vulnerability to become addicted to drugs and their ability to recover from drug use. But we also don't try to minimize the real and tragic harm and danger of drug use. Bree has talked about losing people. I have lost people. We absolutely think that drug use can be dangerous, and we also want to make sure that our friends don't die. Sometimes we get accused of enabling drug use, but I think people who work in harm reduction like us are actually desperate to save people's lives because we've lost people before.
Yeah, this idea, the last slide you talked about, really bringing in, that's something that I really hope that you guys consider and talk about in the discussion piece, if we have time for the discussion piece, is making sure that you're including the clients, the clientele that you serve could be maybe single mothers under the age of 25. Single mothers under the age of 25 is who you should be getting your policy ideals from. Because how is it that a bunch of 40-year-old men coming up with plans of actions that will benefit a 25-year-old single mom, right? So I went to Lansing a couple months ago, and I had to meet with some senators and the OAC, which is the Opiate Advisory Commission. They are in charge of, across the state of allocating the opiate settlement funds to the appropriate places. And so I raised my hand to the nice white man. Well, how many drug users did you ask where the opiate settlement funds should go to? And it was 0. And in that, okay, because 0 people that actually use substances had anything to say or were given any option about where the opiate settlement fund dollars should go, they ended up giving, this blew my mind, but they ended up giving individual counties across the state of Michigan. So every county was given like a representative from the OAC. And that person was supposed to talk to county officials about how they want to use their settlement dollars. And 85% of the counties in Michigan decided to use it for jail-based programming.
So, and unfortunately, that is not an evidence-based approach to preventing overdose. I mean, we do want to offer harm reduction and medication services in jails and prisons, but that's not where we actually really want people. We want them in the community to be able to access those things. So that's unfortunate. Yeah, they also rejected me from being a member of that council. Yeah. They didn't ask me either, yeah. Okay. So when we think about how to help people who use drugs, we tend to have this traditional idea of thinking about, I already showed you the drug use spectrum, right, where we have people with an addiction, a substance use disorder on the right, and then we sort of have like people in the middle who use drugs but aren't really addicted to them, and then we have like no use abstinence. We tend to think the goal of every intervention, move people from addiction to abstinence. That's a goal. We should support that for people who want it, but actually harm reduction says that's one of many goals that could be effective for improving health outcomes. That for some people, we're not going to be able to move them, they don't want to move, and that's their choice. We could at least make sure they don't die while they're using, right? And that's a success. We could move them from maybe a severe substance use disorder to a mild one. That's still an improvement. We can move them from a severe disorder, moderate, or even mild, to maybe just social or occasional use, right? And a lot of people's substance use actually just is in the middle here. This is most people who use drugs are in the middle. They do not have an addiction. They use drugs socially as young people, sometimes binging, you know, but it's not an addiction. That's most people's use, and we can try to make that safer too with harm reduction. We can talk to people about how to binge drink in a way that's maybe less risky, or maybe try not to binge drink more moderately, right? But still allow them to drink.
The forms of using substances is considered like success in harm reduction. So if we're giving folks space to maybe stop IV drug use, which comes with much greater risk than snorting or smoking or vaping, if we can encourage folks and give folks the things that they need to maybe snort safely, like sterile, like I made 100 snort kits yesterday, sterile straws, A&D ointment, vitamin C, lip balm, like all of the things that they need to use to snort drugs safely, because sharing snorting materials can spread viruses and bacterias. But if we get somebody that's been putting a needle in their arm 10 times a day into a space where they can snort and not go into detox and maintain and stay safe and not contract any harm done by syringes, like that's a great success. Do you know how badly your body gets injured when you're poking a needle in it multiple times a day? If that person can stop and only use snorting or smoking, they're already removing so many negative health outcomes of using.
Yeah, so this is the kind of advice that Bree is giving as part of what like syringe programs offer, and I'll cover naloxone first. That's also what syringe programs do. So naloxone, I'm sure you already know, it's the generic term for Narcan. Narcan is actually a brand name for the drug, and I don't want to give pharmaceutical companies free advertising, so I'm going to keep saying naloxone, but I know that's harder to say than Narcan. So naloxone is an overdose reversal drug. It was actually very old, 1961 when it was made, but it wasn't necessarily available to the public until more recently. It was sort of just in hospitals. The FDA approved now recently over-the-counter sales actually of nasal naloxone. But again, the main source for people who use drugs is these syringe programs. They're not going to a pharmacy and spending $45 on Narcan. So how it works is you have opioids in your brain. They want to go and sit on your opioid receptors during an overdose. There's too much of that opioids. They bond your opioid receptors, and they slow down your breathing and eventually cause you to stop breathing. What naloxone does, it has a stronger affinity or sort of bind to opioid receptors in your brain, so it kicks off the opioids, and it sits there instead for 30 to 90 minutes. People can sometimes re-overdose. I mean, it's okay. Yeah, so the person isn't just like good after 30 to 90 minutes because it does wear off. But all clients should be sort of offered naloxone, even if they're now no longer using drugs, because it is very effective. Naloxone and overdose education increases the knowledge about overdose risk factors they can then pass to their peers and then family members. It can increase skills of responding to an overdose event. Of course, it reduces deaths due to overdose. Someone might overdose, but we don't want that overdose to be fatal. The best way to prevent the fatality is to give naloxone. And then we do see actually among people who are trained, people who use drugs who are trained in naloxone and overdose response have some small increase in their sort of likelihood of enrolling in a treatment program. So it's absolutely worthwhile to do.
The first responders out there are the drug users. I think it's important to remember that all of these policies affect the drug users as well, and they're the ones with the boots on the ground. They're the ones at the dope house watching the overdoses happening. So the fact that Narcan wasn't available in their pockets until recently is absolutely wild. Millions of people died of overdoses after Narcan's arrival in the early 70s that didn't have to die because deaths are policy failure, not drug failure. All of the people that I loved that died last week died because our policies suck and they are not given space to live.
And there's this myth that maybe if we give people naloxone or Narcan, that's going to increase drug use or encourage it. There is not a single peer-reviewed scientific study that has ever showed giving people Narcan, naloxone increases their risk of drug use or increases their risk of an overdose. It's just a myth. Please do not let it be perpetuated. Correct it when you hear it. And so we also have Good Samaritan laws in every state in the country now, but some of they vary by state. Ours in Michigan is not perfect. So basically what these laws do is provide immunity from arrest or prosecution for drug possession when someone calls 911 for an overdose. The Michigan law says just the individual who needs medical assistance and the person giving naloxone are protected, but not necessarily other people at the situation. And it doesn't protect people from drug paraphernalia charges and does not protect you from probation or parole violations. So this law should actually be changed to protect from those things because that's a deterrent from calling 911. And there's also no risk of overdose from brief skin contact with opioids of any kind, like fentanyl. If you ever hear a police officer or other first responders say, I'm worried about responding to an overdose because I heard if you touch fentanyl, you could overdose. That's completely false. That is not true. It takes a fair amount of fentanyl exposure through your nose, through like an injection, right? Like that's how you get exposed to fentanyl. Brief skin contact, wash your hands, you're fine. People have talked about to me, well, what about those fentanyl patches that, sometimes cancer patients get? Those have a special formulation in them that slowly releases that. Even if you just put that on you for a second and took it off, you're not overdosing. So that takes time to go through your skin. The problems with these myths is that they sort of reduce people's willingness to respond to overdoses, so please correct them again when you hear them. I want to get to syringe services too. So I've given you on the back of your sheet, your one-pager, a bunch of sites that offer syringe programs. I cannot emphasize enough how important these programs are as a step towards health improvement for patients who use drugs. So these are programs that provide free, unused needles and syringes to people who inject drugs to avoid things like HIV or hepatitis C. They can also sometimes provide smoking supplies, and they can offer other services like PrEP to prevent HIV infection, mental health and primary care. Are they effective? These are one of the most studied interventions to addressing drug use, and they work. There are hundreds, maybe even at this point, thousands of studies about how syringe services programs improve outcomes. So they not only reduce new HIV and hepatitis infections, saving roughly $400,000 in healthcare costs per person. But they also, as Bree has mentioned earlier, mean that people are 5 times more likely to stop or reduce their drug use and then enter treatment than people who don't use syringe programs. So they are not promoting drug use, they're promoting safer use of drugs, and if people want the transition to other services that could help them stop. They also reduce syringe litter and accidental needle sticks in the community. Sometimes people think, oh, if there's a syringe program near me, there's gonna be more needles. It's actually the reverse case. We see less needles in communities that have a syringe program because also the program staff go out and collect them.
I was going to say that is because literally I was outside with tongs and sharps containers, on State Fair, at O'Meara Park, in Palmer Park, all the places that I distribute syringes. If the van is parked there, there's also staff members from that van in the field and in the community and on the streets picking up syringes that were left behind.
Yeah.
That is a part of the idea of syringe service programming. It's literally a part of our operation is to reduce the syringe litter from a time before syringe programming was available.
Yes, so they're actually like very helpful at reducing that in communities. Communities that have syringe programs do not have any increase in arrests or crime. And again, similar to the naloxone stuff, there's no studies that show that syringe programs increase drug use. There is no scientific evidence of that. The evidence is actually the opposite. I also want to get to medications. So we've mentioned a bunch about medication treatment for opioid use disorder in particular, but there's also medications that can be used to treat alcohol use disorder. Unfortunately, we have no evidence-based medications right now for methamphetamines, cocaine or crack, benzodiazepines, or other sort of stimulant use disorders. But we do have 3 really good medications for treating opioid use disorder. 2 of them are better than the other one, though. So it's methadone, buprenorphine, sometimes called Suboxone because it's easier to say. Again, that's a brand name, and I don't want to give these companies money, but that's how people refer to them too, though, because it's hard to say buprenorphine. Yeah, or subs. That's the treatment medication too. Also naltrexone, sometimes called Vivitrol. Again, that's the brand name. So I'm going to tell you about these drugs and why they're so effective. So methadone is an opioid itself. We call methadone and buprenorphine what's called an opioid agonist treatment, or OAT. That means they themselves are opioids. There are 2 different types of opioids. Methadone is what's called a full opioid agonist. Buprenorphine is a partial opioid agonist. It just means they function a little bit differently, but they are opioids. Versus naltrexone is an opioid blocker. It's what's called an opioid antagonist. So these have 3 different types of ways of working. The opioid agonists, buprenorphine and methadone, are more effective, and I'll tell you why in a minute. But one of the things that's true of all 3 is that there's no time limit on how long someone should be treated with these medications. We have actually no idea what is the ideal amount of time, and we think it probably varies by patient. So if someone's on methadone for 30 years, that's fine if they're helped by it. If they're on it for 2 years, that's fine if they're helped by it. We generally think at least a year is needed for all of these medications to start to be effective, and that's partly because people's lives need to get stable while they're on them, and that's a hard thing to do if you're going through withdrawal. So buprenorphine, we often go to as sort of like the one we promote the most, and part of that is not necessarily because it's more effective than methadone, but it's less regulated than methadone, which means it's a little bit easier to get. So it's a little bit of less of a burden on patients. It can be prescribed in primary care by any primary care physician now. You see a special training and waiver, not true anymore. Any primary care provider, any MD, DO can actually prescribe this now. It's sometimes called Suboxone. Basically what this does is methadone and buprenorphine are the gold standard of care. They are the best possible treatments with the best possible outcomes for people addicted to opioids of any kind. They are better than not using them at all, or just using sort of therapy, talk therapy, at retaining people in treatment, reducing their drug use, and reducing their overdose risks and sort of other criminal activities they might be involved in. They also reduce probability of HIV infection. They improve physical and mental health among people living with HIV. And the evidence is just really overwhelming that these medications work. The only reason that we suggest buprenorphine over methadone is that methadone, you have to go to a methadone clinic every day. You have to stand outside in line. They're only open super early. Sometimes people think that's kind of stigmatizing, but methadone really works. If a patient's open to doing that, that's fine. The medication is not the problem. The medication works. It's sort of how we do the medication is the problem. Buprenorphine, you can go to Walgreens and get it. Sometimes pharmacies don't stock it, so you should the healthcare provider should make sure that it's in stock or whatever, but in general, we think these are equally good. So this is sort of a graph showing return to use or relapse rates. The green line is return to use or relapse among people who are just getting talk therapy. A lot of people think, oh, all someone who uses drugs needs is just to go to talk therapy. They just need counseling. Counseling's great for people who want it, but counseling alone is not as effective as giving people these medications. So buprenorphine and methadone, that's the blue and the red line. See how low that is compared to just the therapy alone. So that's why these medications work, and this is with a big study, 56,000 patients in Massachusetts, and this was the trend that they found. So some medication programs require counseling. Some people think you have to do the counseling. You have to get to your root cause issues. Well, yes, if someone wants to do that, that's great, but the scientific evidence for requiring counseling is very weak. So a bunch of studies that were sort of looked at together, what we call a review of randomized controlled studies, found that counseling actually didn't improve outcomes among patients who were treated with methadone and buprenorphine. So methadone and buprenorphine alone are sufficient treatment. If someone wants counseling, absolutely, let's get them that, right? But that it doesn't have to be required. Unfortunately, though, Michigan mandates proof of enrollment in counseling for Medicaid coverage of methadone and buprenorphine. So that is not an evidence-based policy. I would recommend the state change that about their Medicaid policy. Some people are also worried about this idea of diversion. People are going to sell their methadone or buprenorphine because they are opioids, right? Someone could get high off them. People who are addicted to opioids do not get high off these medications. They're dosed in a way that there's really not much euphoria, though, I mean, honestly, kind of like what's so bad about euphoria, but whatever. It's not, they're not getting high off of them. They're basically getting to the point where they're stable. They're sort of be able to act normal. When we see any sort of diverted buprenorphine or methadone, people selling them on the street, typically they're selling it to people who got kicked out of treatment or couldn't get to the methadone clinic on time. So almost always people are using diverted methadone, so what they're buying on the street, or buprenorphine, to prevent cravings, to relieve physical pain, and only like 8% have ever used it for euphoric effects, so to get high. It's very rare. So this is not a huge concern to us in medicine. And sometimes people think, well, wouldn't you just be then addicted to methadone or buprenorphine? Isn't it just trading one drug for another? No. People treated with methadone and buprenorphine have a physical dependence on the medication, but it's treated like, these are both treated like prescribed medications. You don't have to go through a bunch of stuff that's illegal and dangerous to get these medications. You don't have to use them in a way that puts your health at risk, right? Methadone is dosed in a sort of cup in front of a nurse, and buprenorphine is taken either as tablets or a sort of a strip that dissolves in your mouth, right? You're not necessarily using these in a way that's very risky. People treat these medications don't typically have the other markers of addiction in that 11-point list we went over at the beginning. So dependence is not equal addiction. People are dependent sometimes on methadone and buprenorphine in their treatment, but they're not addicted to it. So these are the most effective medications. There also is a third one called naltrexone. It is used to treat both opioid use disorders and alcohol use disorders. The extended release injectable version called Vivitrol is the only one recommended for opioid addiction. Is it effective? Yes. For alcohol, it reduces the risk of return to heavy use. For opioids, it can be effective, reduces cravings and illicit drug use, but it's not as effective as methadone and buprenorphine, and it does not reduce overdose risk. And in fact, for some people, it can increase overdose risk. The reason why: to start taking naltrexone, which is an opioid antagonist, so it blocks the effects of opioids, you have to go through detox. I've mentioned before that detox can be dangerous. Detox is going through withdrawal, and it's managed at a detox facility typically, right? But that's a hard process. People are at the highest risk for return to use in that 7 to 10 day period, because detoxing, going through withdrawal, is very uncomfortable. To start this medication, you have to go through that. Not everyone makes it. That's the problem. People return to use, their tolerance is down, that makes them more likely to overdose. So that's the risk of this one. So only 72% of naltrexone patients in a trial were able to even start the medication, as opposed to 94% of buprenorphine and methadone patients. So we do, especially with a very risky client, which always will be someone who's pregnant, is very risky. Naltrexone is not recommended for pregnant people. Only buprenorphine and methadone are recommended for pregnant people, okay? But then again, you know, if this is not that risky of a patient and they want to do naltrexone, that's fine. Counseling and naltrexone is more effective than counseling alone. It should still be offered. I want to say again that methadone and buprenorphine are the standard of care for pregnant patients addicted to opioids. If they're addicted to other drugs, not opioids, methamphetamine, crack cocaine, whatever, these are not the medications for them. They don't work. It's only for opioid addiction, okay? Those people could potentially go to detox. For opioid addiction, though, no detox for pregnant people. It is extremely dangerous. You're putting them at higher risk of overdose and death. They should be transitioned as soon as possible, as soon as they're ready, right, to buprenorphine and methadone. That is the standard of care. We know that reduces their risk of overdose. And it actually, even though these are opioids, reduces the risk of their children being born with neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. It might sound weird. You're like, well, but it's an opioid. Wouldn't it cause that? The comparison that we use, though, is to heroin and fentanyl and the illicit market. Those, the variability of those in the baby, right, makes the baby more likely to get NAS or NOWs than if they're on the stable dose of methadone and buprenorphine. That stability of those medications actually makes it safer, and the NAS is much less likely in that population than someone who's using the illicit opioids, okay? We do not compare to abstinence because abstinence is too dangerous for that population typically. Do you want to add anything to that?
Well, I was just going to add, because in this specific topic about like drug user health while they're pregnant, it's often like questioned about how are these things safer, right? Because, well, they forget that we're not measuring it against abstinence, because we're talking about a person that came in pregnant using substances. This isn't a new situation that is being placed on the patient already pregnant. So they're coming in, living with the substance use disorder, pregnant already, so abstinence isn't an option. So we're not measuring the success against that. The other thing that people tend to forget is the biology of our body and the filter of our placentas. So like they connect drug use while pregnant to like the worst positive impacts that could have on a fetus, when in reality, cocaine actually has longer term negative health effects for babies born on cocaine than heroin, although heroin is definitely viewed more negatively, in my opinion, than cocaine because of the affluence difference, like cocaine being a white drug and heroin and crack being black drugs. And then, so the other disparity would be that they are measuring these things against things that are not attainable for that person at the time.
Yeah, and you might say, well, but abstinence is the best possible outcome. Yeah, it's not realistic. And by suggesting that this is the path the person should go on, you actually put them at greater risk, okay? So we really need to, again, have that harm reduction perspective. The best possible outcome statistically in all the studies, buprenorphine and methadone treatment, that is what works. So that is what should be offered to the patient.
I was on methadone the last time I gave birth, and it was very highly encouraged to me to breastfeed because I would have just enough of the methadone come out in my breast milk, not a great amount, but just enough to relieve the symptoms of the neonatal opiate withdrawal syndrome that the triplets were living with. So I pumped, and the nurses would feed the babies my milk on methadone because they knew that this was like a measure and evidence-based practice that gave us the best possible outcome.
Yeah, and NAS and neonatal opioid withdrawal syndrome are treatable. There's much more significant conditions that are showing up in that NICU than these conditions. Treatable. We don't think there's huge long-term effects to it even, right? It's just something, it's an acute thing that we treat in the hospital. Some of the things that we do are things like giving the breast milk of the mom because they do need some exposure to opioids slowly and they're weaned off. So we know how to treat it. We can, and we absolutely want to reduce it. But the best way to reduce it, methadone and buprenorphine, okay? There's also some other types of more sort of like controversial harm reduction interventions that only some areas of the U.S. are trying out, and one of those is overdose prevention sites. We just wanted to mention them. New York City has one, and basically all this is a site where people can use drugs under supervision, and there can be an immediate response to an overdose. So New York City has the first one in the U.S. That's actually legal. It's called On Point, and research shows that these work for reducing overdose deaths, and they do not increase illicit substance use. But in Detroit, we don't have one. I think we're a little ways off from this, but
it's still very illegal here. I will say, so safe using or safe consumption sites have been used across the world for several decades. A lot of other countries have really embraced harm reduction long before it even became a conversation here. And in the world view of safe consumption sites, there is not a single recorded death of an opiate overdose happening there. So like if that's all the information that we have about overdose prevention sites, then that should be enough for them to be legal. If we just know they haven't killed anyone when we keep burying people, then like that's the kind of opportunity of doing things differently because we know what we've been doing isn't working.
Yeah, because as Bree has mentioned multiple times, using drugs alone is extremely dangerous. No one can respond, no one can identify if you have an overdose if you're alone. There is actually a national hotline called the Never Use Alone hotline that people can call and someone will stay on the phone with you while you use. That's better. Like anything besides using alone is better, right? Because no one can respond to your overdose then. So this is another type of way to make sure people don't use alone. So there's a lot of Detroit harm reduction services. There's a list on the back with a QR code. You can use your phone to access their websites. So Brook works for access. They have a syringe program, primary care. They have everything, specialty addiction treatment. Clearview is probably the only residential treatment I'm going to suggest to you guys. In general, a lot of residential treatment is not very effective. Unfortunately, that's just the case. A lot of them don't allow methadone or buprenorphine treatment in their facilities, and that's part of the reason why. But also they just don't use evidence-based practices many times. But Clearview does. They have medications for addiction treatment. They have residential treatment. They have special services for pregnant and parenting people. They allow children to reside there. Specialized services for women, trans and cis women clients, especially those with a lived experience of abuse or assault. So highly recommend these two services. And then there's some sort of like harm reduction programs like CHAG in Southwest Detroit, thank you. who I work with on research. There's Detroit Recovery Project, who also has a mobile syringe program. And then there's Harmless, which is another mobile syringe program. They also do wound care and street medicine, and that just means they have doctors that go out in the street and offer people services.
So my sister actually runs that program. So it's kind of like a family affair. One of my really great friends runs On Point in New York. It's extremely successful. And I think even in the experience, and New York is such a bigger city than Detroit, and the using population is so much greater there, and the unhoused population is so much greater, that I can say he is very much seeing like an impact on the community as to having like somewhere safe to be able to use substances.
Yeah. And I will say, one of my friends who died from an overdose was in New York City in 2013 during one of the fentanyl waves and used alone. And if he had had access to On Point, he might be alive. You know, this is someone who has a master's degree in neuroscience. Like, it's just a waste, dead at 26, you know. So common hesitations towards harm reduction and MAT are things like, well, you know, but abstinence from drugs is the healthiest outcome, so that's what we all should promote. Or things like harm reduction encourages risky drug use, or medications like methadone should only be used for a short time, otherwise it's the same as using heroin, or I don't want to work with people who use drugs because they never recover. So I'm hoping that we've addressed some of these myths and hesitations today and shown that these are really not evidence-based statements or things that we can really work towards changing about how we see people who use drugs. But we do also want to sort of ask you about some action steps that you can think about. Like, what would be an action plan to tackle substance use stigma and promote harm reduction in your work that you could do today, the next 30 days, the next year? And then maybe what are some of the barriers to implementing stigma reduction or harm reduction in your work? So we have like just a couple minutes really for discussion, but we would love to hear any thoughts. I mean, this is also the million-dollar question. It's hard to do these things when policies are telling you not to.
And just keep in mind that like change is slow, right? Like the expectation isn't that you'll leave here today and walk up to your supervisor and say, here are the list of policies that are causing harm to our drug using clientele. It is slowly incorporating them. And most often the success that I see is when social workers and individual providers make those changes within their practice with their client. And then it starts bleeding out into the people that you're training, into the newer social workers coming into the field, into the people that are sharing a space with you, and then policies start catching up. So the question that I would like for someone to answer is something that they can do on the level of individual practice with their clients that represents more of a harm reduction, person-centered care approach versus a punitive, punishing approach to drug use. That's a really great, and that's probably one of my favorite answers to this question is just going through hiring practices and documents that are within office to make sure that there's a pronoun line and things like a word edit. So many things are just an edit. And another example is like I do HIV testing for the CDC twice a week, and they give me a script. It's the only organization that I have to read a script for because they're very specific of how the testing process looks. In that script is the word infected 3 times. We do not use that word in the HIV field. I am a harm reductionist and HIV expert. That word is not used. I teach nationally And I've never heard anyone in any space that I've been in refer to folks living with HIV as infected humans. We have long decided that it was inappropriate to call humans infected. So but like the script that I literally got last month, which was the most updated one by the Center of Disease Control, sent to me from Atlanta, Georgia, had the word infected. So it's like those simple those simple moments where people like doing the office work, the boots on the ground work, the grant writing work are like, wait, the language isn't lining up.
So what would you use instead?
A person living with HIV. Or a person at risk of acquiring HIV, or a person receiving HIV prevention services.
Yeah, so we don't have that in the language terminology, but again, you can see that person-centeredness for all sorts of stigmatized situations. Yeah.
Yeah, another term that's really unique to the syringe service world too, instead of clean or dirty, is just identifying tools as sterile or not. Like, are these sterile syringes or are they unsterile syringes? Is your kit that a lot of drug users carry kits around with all of the things that they use, and so oftentimes I'll ask them like, when's the last time we've sterilized your kit? Like, can we just dump it out into the trash? Wipe it down, some Lysol, new syringes, new pipe, new tools, kit is sterile. Like referring to the things that people have an attachment to, even if we don't understand it as dirty or clean, can be really harmful to a person's perception of self. So I feel like for me, the clean and dirty word specifically is more of how we prevent people from internalizing shame and doing like an internal stigma. Because just having to refer to something that you carry and is important to you as a dirty thing can just really negatively impact your view of your own personhood and what you have and care about.
So do you guys have any questions for us before we leave? And then here's our contact info if you do have any additional questions. We'd be happy to answer. But okay. Well, we hope this was helpful. And we appreciate your time. Yeah.